All right, so we still have only 15 participants. I guess we're gonna wait just a little bit more. Other than that, Dr. Robichaud, are you ready in 2 to 4 minutes?
Absolutely. And it's not going to take 30 minutes. I was giving 30 minutes, but it's more like a 15, 20.
Great, quick hits.
Let me know when you're ready.
All right, we'll do. All right, so we'll start shortly. So if you guys were expecting Jake or Anne-Sophie to be there and host today's academic half day, well, unfortunately, you won't see them because they're both on vacation or off. So it's going to be me who's going to be doing actually a test run for next year. So without further ado, I'll let the floor to Dr. Robichaud, who's going to do a presentation on POCUS and Tamponade.
Okay, can you hear me well?
Yes.
Yeah, and you can see my slides?
Yes, we do.
Okay, good. So let's get started. So yeah, it's going to be a short talk about Tamponade. I think I don't see anyone here that was at Cape, but it's pretty much one of the talk that I give at Cape. Maybe except Corinne, I think, who was there, but I don't see her. So that's good. So let's get going. I don't have any disclosure for this presentation. And in terms of objective for the presentation, I want us to kind of review the basic pathophysiology of tamponade, because that's important to understand why we're using ultrasound to look for those findings that we're going to actually discuss. And by the end of this talk, I hope we're all able to name 4 POCUS findings that are key in terms of diagnosing tamponade. And we're going to try together to integrate this new knowledge in the real life scenarios that we're going to do at the end of the presentation. So let's first review tamponade. So tamponade 101. So remember that to have a cardiac tamponade, you kind of need to have a pericardial effusion. And pretty much any patient with an effusion is at risk of developing tamponade. Of course, it's always rate more than size. So even though you have a super large effusion in a cancer patient, if that patient has been accumulating that effusion over years, the chances of you developing tamponade quickly is very low, because the pericardium will have time to stretch and the pressure will have time to accommodate. However, if you have this morning a young guy that gets stabbed in the chest and then brought to emerge, all of a sudden this guy will have an increased pressure in his pericardium from the bloody effusion. And that will put him at high risk of having tamponade. Why? It's because there's a rapid rate of accumulation of the effusion, which is the key factor in developing tamponade. So pericardial effusion, rate more than size. And of course, this is a clinical diagnosis, but I would actually argue that it's not only a clinical, it's also a sonographic diagnosis. You should have both the clinical correlation, but also the ultrasound findings. And POCUS is just such a fantastic tool, first of all, to diagnose the presence of an effusion. But then once you recognize as an effusion that's either acute or big, and you're worried about tamponade, to kind of give you either reassurance or a little bit of worry in terms of this patient should probably get admitted and worked up a bit faster, and perhaps pericardiocentesis. Pericardial effusion, let's talk about it. So the best view to look for pericardial effusion is the subxiphoid view. So don't underestimate it. It's an old view that is actually your, they'll give you the best buck for your bank whenever you're looking for that effusion. Typically, we're going to characterize an effusion as small when it's less than 1 centimeter. And the way you measure it, I hope you see my mouse, you're going to go from the, let's say, liver edge to the RV free wall, and you're going to measure approximately the distance. You can just like freeze it, go back, you say, you know what, this is pretty much where I would measure it, to be honest. And here you can see on this video, it's actually circumferential, but it's tiny, tiny. Okay, so a small pericardial effusion. In contrast, if we look on this side, subxiphoid view again, we see that this one is way bigger, right? And typically we're going to say that anything that is considered a large pericardial effusion is going to be more than 2 centimeters in size. The other best second view, or the other view that you should be using to diagnose pericardial effusion, and actually we're gonna discuss about it a bit later, but that's quite useful, is the parasternal long axis view. In this view, always make sure that you identify a key structure, that is the descending aorta. So you can see on this video here, we have the descending aorta right here. And it's key because the pericardial effusion will always track in front of the descending aorta, in contrast to pleural effusion, which we'll see in a second. So on a parasternal long axis view, a small pericardial effusion is going to look like this. Again, less than 1 centimeter. In contrast, a large pericardial effusion, here you can see it's actually circumferential, will look like this. And again, make sure you identify the descending aorta. And here, yes, Lori, you could have increased the depth a little bit to give us a bit of a view of that descending aorta, but I'm telling you that's what it is. And that's the point I wanted to make in terms of always making sure you identify your descending aorta, because what you want to make sure is that you're not falsely identifying your pleural effusion, which you see on the right of the screen. So on the right of the screen, you have a very unusual scan where you have both a pericardial effusion and a pleural effusion. And again, descending aorta is right here. The pericardial effusion will track in front of the descending aorta, while the pleural effusion will track behind. So make sure you don't go ahead with a pericardiocentesis if you identify this. You actually need to do a thoracentesis then. Okay, so now that we know how to recognize pleural effusion, a little bit on how to characterize its size, and again, size doesn't really matter, but sometimes it actually is going to give you some other clues. Let's look at what are the sonographic signs of tamponade. There are 4 signs. The number one you should know, the hallmark finding, is RV collapse in diastole. We're going to go through every one of them together. The second one that I find the most useful is the IVC plethora. So it's really your confirmatory finding. You see RV collapse in diastole and you see IVC plethora, you should be worried about this patient being in tamponade. The other 2 criteria or findings are kind of interesting, maybe more for you guys that are more advanced in ultrasound. So RA collapse in systole is actually the earliest sign. It will happen with a very small effusion, but that's kind of cool to notice or to see on the ultrasound. Then finally, the really, really cool trick is the sonographic pulsus paradoxus. So forget about that BP cuff. I really want you to give it a try with the ultrasound probe, and I'll show you how. So what is this hallmark finding, the RV collapse in diastole? So here's a parasternal long axis view, and I'm going to identify the structures for everyone. So this is your RV and your RV free wall, right? Because this is septum, this is free wall. This is your LVOT, your aortic valve, your left ventricle, your left atrium. And this is your descending aorta. Again, important to mention it. Here we have a large circumferential pericardial effusion. What we are looking at is, are we having the RV free wall collapsing during diastole? That is basically the sign we're looking for. But then you're going to tell me, well, that's kind of hard to know, right? That's called also the little man jumping on a trampoline. I don't know if you came across this, but it's basically if someone was boom, boom, jumping on that RV free wall every time you are in diastole. How do you know you're in diastole? One of the things you can do is use the M mode. So M mode is not only good for pneumothorax, it can be useful to kind of assess the timing of opening of the valve and RV collapse. I'm going to take my M mode cursor and I'm going to go through my RV and then again through my mitral valve. And look at this here. So the black is the effusion The white line here that I am identifying with my mouse is your RV free wall. And here is the mitral valve opening, so the E and the A wave. So every time my mitral valve is opening, this is ventricular filling, this is diastole. So mitral valve is opening, I get an RV collapse. RV free wall is collapsing during diastole. That is very concerning. Just for you that are a little bit nerds and want an ultrasound later on, the longer you have your RV wall collapse during diastole, the sicker your patient is. So it really corresponds to the case of the patient. So if you have a very long RV collapse during diastole, not just a dip, like a prolonged dip, that's actually quite worrisome. Okay. But when you get this here, and let's say you have a swinging heart because it's a super, super big effusion, the patient is uncomfortable, is breathing fast, forget about the M mode. You're going to be looking at me, Lori, what are you talking about with your M mode? I can do this. This is my trick. What you can do, you can freeze your image. I'm going to do it here. I'm freezing my image and I'm going to cine loop here. So on the ultrasound machine, you actually can do this. So I'm going to look for, and again, this is mitral valve here. Look at the mitral valve when the leaflets are opening. Oh, see, my leaflets are open now. Now I want you to really have a look at the RV free wall that is right here. Okay, let's have a look together. So mitral valve is closed, mitral valve is open. What's happening to the RV free wall when it's opening? It's collapsing. So I can for sure identify RV collapse during diastole with that little pearl. So freeze the image, cine loop, and look at that RV free wall. That's my trick. And that's how I assess to see if I do appreciate this. The M mode can be really tricky when your patient is sick and tachycardic. Good. I hope everyone is good with this. I cannot see the chat right now, so we can maybe take the questions at the end and we can come back to the videos. So once you've identified that RV collapse in diastole, one of the things I want you to go right away is go look at that IVC. What we're looking for is this, a plethoric IVC. What's a plethoric IVC? It's an IVC that doesn't move, that it has a big diameter, that is full, and that doesn't vary with respiration. So there's absolutely no inspiratory variation when you take a big breath. Don't do the sniff thing. Again, this is completely out. It's just the passive respiration is the way to assess for the IVC. So if I see this, and again, you can recognize the large effusion, you know there's RV collapse in diastole, and you see this is actually very concerning. However, if I see this, a non-plethoric IVC that is, not completely full and does have some respiratory variation, that assures me a lot. I know that I have time with this patient. How good is this? You're going to tell me, the IVC, I heard it's not that good. Actually, the IVC for Tamponade, and that's a really cool little article that I will send you after rounds. It's like 5-page, is very, very sensitive. It's a very useful test because of a high negative predictive value. So if you don't have IVC plethora, good, reassuring. But if you do have IVC plethora with these other signs that we talk about, you really have to keep that patient. Like, don't be a hero. This is the type of patient that will not do so well. Good. So these are really the two signs that I really want you to remember. But what are some of the other signs that can clue you in that maybe we're dealing with, like a pre-tamponade, for example, someone who's developing increased pressure in the pericardium? So same principle as the RV collapse in diastole, you can get RA collapse in systole. So here we can see the left atrium, the right atrium, left ventricle, right ventricle. And again, instead of jumping on a trampoline, now he's punching the RA, that little man. That will occur very early in the presence of a pericardial effusion because the RA is this very low pressure system, doesn't have a lot of muscles on the wall. So it will go in very easy with only a minimal increase in the pericardial pressure. So that RA collapse in systole is right here. Okay, sonographic pulsus paradoxus. Okay, don't be scared. We're going to go through this together. So if all of us right now, I hope we're all healthy and we don't have a tamponade or like pericardial effusion. If we all now take a big breath, so everyone take a big breath. When we do this inspiration, we increase our venous return. We suck up the blood from the vena cava and our RV will expand, right? Because you just filled it with blood. You will get a really small, by doing that, you will get a little bulge of the interventricular septum into your left ventricle, and a little bit of a bulging out of your RV free wall. So your RV will expand like this. This little bulge in the interventricular septum will decrease your systolic volume by like a very small amount of blood. This will lead in a decrease in blood pressure. You'll have a very small drop in your blood pressure every time you take a big inspiration. Now imagine you have a tamponade patient. So instead of being able to open up your RV, what's happening is that RV free wall, it's like, I'm not moving. There's so much pressure on the other side that I cannot move. So the only place where your RV can move is the interventricular septum. So what's happening is everyone take a big breath, but now we're in tamponade. The RV cannot expand. So the only way that it's going to expand is towards the left ventricle. So you're going to have an exaggerated septal bulge into the left ventricle, and that will lead in a significant decrease in your systolic volume. And that will give you that big difference in blood pressure that you get with tamponade, you know, when you take the blood pressure cuff. So that's the whole rationale before the pulsus paradoxus. So how can you do this without a BP cuff, but using your POCUS machine? So what you need to get is an apical or 4-chamber view. And what you're going to do is you're going to put the pulse wave Doppler right at the tip of the gate. You're going to put the gate right at the tip of the mitral valve. And what you're looking for is, so look at this here. You have a high peak and a low peak, a little bit higher. Oh, this is my highest peak and this is my lower peak. So what you want to do is measure the difference between the highest peak and the lowest peak. Forget about inspiration, expiration. The only thing you want is highest, lowest. You want to see that variation in the inflow of the mitral valve between the breathing episodes. In the normal healthy patient, that variation is going to be less than 15%. We all have a variation. Again, when we take a big breath, the systolic volume will go down a bit. Typically, the mitral valve will be less than 15%. However, in a sonographic pulsus paradoxus or tamponade patient, you're going to have an abnormal inflow variation. There's going to be a significant decrease in the highest peak and the lowest peak. It's going to be more than 25% variation. So that together with all the other signs that we saw will kind of give you a bit of a confirmation that you are dealing with someone who has a very abnormal pericardial pressure. And that will kind of be one of your confirmatory, very cool trick finding that you could use. So these are the 4 signs I wanted to talk about. So remember, these 2 are really important, and these 2 others can be useful in certain situations. So let's go through cases together. And again, I don't see the chat. I don't like when it's like this. But
There's nothing on the chat for now.
Good. No, but I want you to give answers. Okay, case number 1. You have a 50-year-old man with shortness of breath for 1 week. This is what we see. So is pericardial effusion, yes or no? And that's a subxiphoid view, but using a cardiac probe, just so you don't get confused. So yeah, looks like there is a pericardial effusion right here. Oh, now I can see the chat. I mean, so yeah, so you do have a small pericardial effusion right there. So is this patient in tamponade? My God, I'm having trouble with my thing. Looks like they might be RA collapse in systole. Maybe this RV is collapsing. I don't know. I would have to freeze. But remember, tamponade is a clinical diagnosis also. If this patient is rock stable, he developed effusion for like years, honestly, these signs are not relevant. Maybe a bit concerning. Maybe I'm going to get a formal or cardiology perform ultrasound, but this is not the type of patient I'm going to move rush to recess if he's fully stable and completely asymptomatic. So remember that. Okay, sorry, that was a trick question. So 69-year-old woman with shortness of breath for 1 week. And these are vitals, right? Okay, now you got my attention. Now maybe this patient could be in tamponade, right? Heart rate 139, blood pressure is a bit on the low side. This is her ultrasound. So pericardial effusion, yes or no? Yes. Yeah, it's actually a big one. Patient is tachycardic. You know the electrical alternance? You're going to see it sometimes on the ultrasound when there's got a big effusion and the heart is basically swinging. That's the whole rationale. It's because there's a swinging heart in a pool of effusion. That's what's giving you electrical alternance. So very concerning ultrasound. And then what if I tell you there is RV collapse in diastole?
Would like to see the IVC then.
Yeah, that's it. So I tell you the IVC is plethoric. Yeah, so you're very concerned that this patient is actually in tamponade. This is the type of patient you move to resus, you start volume resuscitation, and you call for help. 78-year-old with weakness. And, blood pressure may be on the low side or borderline, but the heart rate, he's not tachycardic and he's not beta block. And then you see this. Again, that's a subxiphoid view using the curvilinear probe. So a pretty big effusion, eh? I'm going to give you some other views. So that's the M mode. And again, so here we have a small effusion. So that's why we're having trouble here. But we don't see much of a bulge into the, actually that's your effusion and that's actually your RV. You don't see much of a bulge in the, well, that's your RV above. I don't see any RV collapse during the mitral valve opening. So that's reassuring. Oh, but I see this here. What's this sign? That's the RA collapse in systole on the apical 4. I look at my IVC. There is some variation. The patient looks like when it's breathing, the IVC has some variability. So this could be consistent with a pre-tamponade. You have a pretty large precardial effusion, but you don't have any of the concerning sign. However, you do have the RA collapse in systole. Again, this is a type of patient you just want to be suspicious that, it could be at risk of developing something. This is an early sign. It's not perfect, but then again, might need to have an ultrasound earlier rather than later. So I wouldn't wait for 6 months for that patient to get an ultrasound. 19-year-old man, and that's the real case, shortness of breath, tachycardic, hypotensive. And this is your initial ultrasound. So effusion, yes or no? Yeah.
Yes, effusion.
Check. Yeah, it's more than 1 centimeter for sure. Okay, and then we're like, okay, let's have a look. Is there RV collapse in diastole? And I'm going to do my trick here. So let's see the mitral valve opening. Oh, the RV is collapsing. Patient is clinically, hemodynamically compromised. I have a large effusion and I have this. Now I'm concerned, right? Let's look at the apical 4. Again, quite a large effusion here, eh? And then you could appreciate RV collapse here, but it's difficult because there's a lot of artifact. And what do you see here? Well, you also see RV collapse in systole. So that's kind of cool. So far, he's had 3 out of 4 signs. 2 out of 4. And we see this. This is the IVC. E, right? Not much variation here. And it's super plethoric, like big, big, big. Okay, now you're scared, right? Because you know that this patient is definitely in tamponade and doesn't look so good. And he's actually very, he's hypotensive and tachycardic. So you move into recess. And of course, there's a planting recess. And all of a sudden, the nurse tells you that, oh, well, the patient really looks awful. He has distending neck veins, he's pale, he's gasping for air. You're very, very, very concerned about him. And now he's like even more hypotensive. So what do you need to do? Right? You look around and you look for help, but then you realize the help is you because it's 3 in the morning and there's no one here. So this is the moment you're going to get your needle. This is the type of patient that you will go ahead and perform a pericardicentesis if there's really no help available, because this is a perfect example of a crashing tamponade patient, and you can really confirm that this is your next step. Of course, there's going to be fluid resuscitation, but at one point, once you hit the Beck trial and the patient looks awful and going decreased level of consciousness, you really have to get ready to do this because your patient is imminently dying. So take home for this presentation, that was pretty short. Tamponade is both a clinical and a sonographic diagnosis. Make sure that you always try to correlate both together before you actually call the cardiologist or you send the patient home. POCUS is a fantastic tool for the evaluation of patient with pericardial effusion, but also for suspected tamponade. And I really want you to try it. And the next time you see someone with suspected tamponade or a large effusion, give it a try, because once you integrate this, you're really going to be either reassured or be kind of able to confirm a bit quicker that these patients might need earlier intervention. I see there's some questions in the chat, but you can also ask verbally if you have any questions. So same signs if patient is hemorrhagic hypovolemic shock. Yeah, you'll have the same signs, except that, yeah, your IVC could be still collapsible. And so this is one of the things. These patients, I usually fluid resuscitate them aggressively to really help temporizing the measure. And yeah, it can be absent in low pressure tamponade. It can be absent. You know, there's some pitfalls with this. And that's the problem is if I go into this, it's very advanced topic, but every patient that has some chronic pulmonary hypertension or chronic RV hypertension, The RV is quite particular, can have some of the subtleties. But I would say for most of the patients we deal with in the emergency room who have tamponade, these are the signs that you should be looking for. And yes, you could definitely see in trauma that you have a low pressure tamponade because the patient is exsanguinating from somewhere else. Any other questions?
Great presentation. I really like the way you structured with those 4 quick hits and hammering them down. All right. So if we don't have any more questions, then I guess it's going to be Alexandre El-Haloui, who's going to be presenting his CAT topic on the use of LP and subarachnoids. Alex, you there? Yeah,
hey, you betcha. You bet I am. Okay, so I'll go ahead and share the screen. Very good.
All right.
Let's turn this off. So, hey everyone, nice to see some friendly faces on the call. Thanks for being here this morning. My name is Alex El-Haloui. I'm one of the EM+1 residents this year, and I'll be presenting my CAT topic, which talks about the use of lumbar puncture in the diagnosis of subarachnoid hemorrhage. I know we have some learners and clinicians of different, amounts of experience on the call, so I'm going to do my best to give some good info for every level. I would encourage you to listen along and maybe write down a few things that you learned over the course of the talk, and I'll be happy to have your feedback also at the end of the talk. Either over the chat. You can say it also out loud or by email. And of course, I'll do my best to keep it entertaining. So I think what I'll do is I'll start with an anecdote. Seems like it's pretty popular for this crowd. So I was in the emerge the other day, and I saw this patient for the purposes of this talk, who was coming in with the worst headache of her life. It started all of a sudden while she was preparing her CAT topic presentation. Full disclosure, this was not one of my esteemed colleagues who will be presenting later today. But if you can write in the chat, please, for 100 Zoom points, what is the technical term of the entity that this patient is referring to? Very good. I'm getting a lot of thunderclap headaches. That's excellent. The people who are thinking subarachnoid hemorrhage, good thought, but make sure you remember to read your question stems carefully. So this is, in fact, patient is describing thunderclap headache, which has a technical definition. It's a it's a headache that reaches 7 on 10 or more in intensity within less than 1 minute. So for some worrisome causes of thunderclap headache, I think the patient is saying this, the astute emergency physician might need to think of the following things, right? So it's a list of worrisome causes of thunderclap headache, the most common of which is subarachnoid hemorrhage. And then afterwards, it's reversible cerebral vasoconstriction syndrome. And then otherwise, you have some uncommon causes. I haven't listed them all here, but I've gone ahead and put them in there. Cervical artery dissection, hypertensive emergency, Press syndrome, intracerebral hemorrhage, CVT and CVST, or spontaneous intracranial hypotension. So let's look a little bit more at the most common cause of thunderclap headache, which is the subarachnoid hemorrhage. Most commonly, it's the consequence of a ruptured cerebral aneurysm in the brain circulation that most often occurs in the branch points of the circle of Willis. And these branch points are subject to very high degrees of intravascular turbulence, and they experience a lot of wall stress. And what happens is there's like wear and tear of the internal epithelial, the internal endothelial layer of the artery, and as a consequence, they become structurally vulnerable to the development of these aneurysms. So what's the presentation of thunderclap headache? So it's quite variable actually, but the most common presenting feature I've seen, between 50 and 70% is sudden severe headache that usually lasts several days. And otherwise you also have loss of consciousness. Patient could come in with they call it a sentinel leak headache. So it's your aneurysm that like bleeds a little before really bursting. And they found that it's, a good fraction of aneurysmal subarachnoids who present with sentinel leak. Otherwise, delirium, seizures, neck pain and neck stiffness, stroke, and other findings that I haven't listed here. So how do we diagnose it? With such a variable presentation, it can be quite challenging. This is the approach that I found on UpToDate, which suggests a plain head CT, so CT head, no contrast. And if the CT is negative, then you have to do a lumbar puncture. So this is me thinking about needing to do an LP with 36 patients waiting to be seen. And, it's not, whoops, beg your pardon, take it easy, Alex. So basically it's not it's not the LP itself that's the problem. It's, okay, let's just switch this, stressing me out, this GIF or this GIF, depends how you pronounce it. It's not the LP itself that's the problem. It's everything about the LP. No, I'm joking, but for real, it's a time-consuming procedure and it's invasive and it's not always easy to perform, especially if your patients are altered, they have difficult mobility, and all these things basically brought me to this question. Can we rule out subarachnoid hemorrhage without an LP? And so my CAT project was born. And here we are now. So normally what I would like to do is go through the different strategies, take some time to go through the different strategies to rule out a subarachnoid hemorrhage. But, there are precious few minutes on the clock. So let's get through the first ones really quick. History and physical exam, let's do it fast. Bottom line is, if you have a patient who has just the thunderclap headache and no other associated features with a normal neuro exam, you still can't rule out subarachnoid hemorrhage with your history and physical. So that one's done. Clinical decision-making rules. I think what I'll do for this presentation is I'll just skip it because, again, we're a bit tight for time, with the caveat that, if ever I have a bit of time at the end, I might talk a little bit about the Ottawa and the Emerald, the sort of newer Emerald subarachnoid hemorrhage rule. But I'll really try and stick to the money here. We'll go for where the money is and go with the investigations themselves. So there are three main modalities that are easily accessible to us in the Emerge that can help us rule out subarachnoid hemorrhage. And these are lumbar puncture, which I'll say up front is actually considered by many sources that I've come across as the gold standard for diagnosing subarachnoid hemorrhage. We've got CT head C-, or as the cool people call it, non-con head CT, and CTA of the head and neck. So we'll go ahead and go through them one by one. We'll start with the lumbar puncture. Basically, it should include an assessment of the opening pressure, CSF studies for red blood cells, and an assessment for xanthochromia, which is basically an evaluation of the color of the CSF to see if it's turned yellowish, and that's the consequence of the degradation of the heme, I think, into bilirubin, and that happens over time. So some strengths, like we mentioned a bit earlier, it's the gold standard for subarachnoid hemorrhage diagnosis, and it can detect, blood or evidence of blood up to 12 days after the onset of, I wrote headache here, but it's actually that the presenting symptom. Otherwise, I wrote that it's recommended in ACEP's clinical policy for the evaluation of subarachnoid hemorrhage, but actually it's recommended in probably the majority, if not all, of the texts and the sort of guidelines and recommendations for the assessment of subarachnoid hemorrhage. And finally, if we think of thunderclap headache more broadly, it can help us, LP can help us identify other causes of thunderclap headache. So, we're thinking specifically like intracranial hypotension, and sometimes even meningitis, which more often presents with gradual onset headache, but sometimes can do subarachnoid. Okay, so this is oh my Lord, the weaknesses. All right, no problem. So let's try and do them. For procedure that has that's supposed to be the gold standard, it's got quite a lot of weaknesses, but we'll try and do a few at a time. So it's invasive, it's time consuming, and it's a difficult procedure to do with uncooperative patients. Xanthochromia takes 2 to 12 hours to develop. So if you do your LP a bit early, then there's a chance that you might miss it. And then there's also the risk of the bloody tap, which is really, let's say that again. It's really a not negligible risk of having a bloody tap. And then if you do that, then you're sort of shafted a little bit for trying to find blood on your CSF. Of course, we have to mention there's a lot of associated risks for the patient, anxiety and discomfort, post-LP headache, and the list goes on. And finally, and maybe the most importantly, there's no established or universally agreed upon diagnostic for subarachnoid hemorrhage. So, I think classically what they talk about, the findings of subarachnoid hemorrhage on LP are elevated opening pressure, a red blood cell count that doesn't decrease over the collection period, so over the course of your different tubes. I'm just seeing that there's something in the chat. Okay, great, thank you. And basically that there's supposed to be Oh, I beg your pardon. And there's supposed to be xanthochromia on your classical findings. There was one study that I was able to find that maybe was the best thing that I was able to find with regards to like cutoffs and so on. And it was published in the BMJ by, you might have guessed it, what's his name, Jeff Perry and Ian Steele, who developed the Ottawa subarachnoid hemorrhage rule and have done quite a lot of work in the field of subarachnoid hemorrhage. Basically, it was a study that tried to account for the CSF findings of subarachnoid hemorrhage in the context of a traumatic tap. And what they were able to find was a negative CT head without contrast with CSF red blood cell count of less than 2,000. And no xanthochromia rules out an aneurysmal subarachnoid hemorrhage with a sensitivity of 100%. First of all, we have to keep in mind that aneurysms are the major but not the only cause of subarachnoid hemorrhage. Of course, we've got AV malformations and coagulopathy and so on. And the other problem with this study was that the confidence intervals were pretty wide. So sensitivity estimate of 100%, but possibly as low as 75%. So for the CT head now, this is the non-con CT head, which is I think has potential to be the chosen one for subarachnoid diagnosis without LP. Strengths, very strong, non-invasive strategy. There's no contrast exposure, and you're able to actually rule out a subarachnoid hemorrhage if you meet a specific set of conditions that I found were pretty reasonable. This finding was published in a systematic review and meta-analysis by Nicole Dubosch that she published in 2016, where basically the author selected 5 high-quality papers that included about 9,000 patients. Everyone had a CT head, and of the people who had a negative CT head for thunderclap headache, the majority of them had an LP and clinical follow-up to diagnose or to rule out subarachnoid hemorrhage. And what they found was that in patients who had an onset of thunderclap headache in less than 6 hours, and a normal neurological exam, and with the CT being read by an attending level radiologist, and who presented with thunderclap headache as their main chief complaint rather than primary neck pain or syncope or seizure, they were able to rule out subarachnoid hemorrhage with a sensitivity of 98.7% of patients, with, again, pretty tight confidence intervals in this study. I find, honestly, this is something that I could work with. It's pretty solid, but the 6-hour window, I don't know, I'm not into this so much. It seems a bit tight, So what I was curious about was how the sensitivity would change with time. And lo and behold, there was a study that looked at that. And what they basically did was they checked a non-contrast CT head for thunderclap headache presenting after 2 days, 3 days, and 5 days. And these are the results. Day 2, 86%, looking pretty good there. I mean, it might not be so bad if we weren't dealing with subarachnoid hemorrhage, but I don't know. I think if the patient was coming in with not a totally clear story, or maybe a bit of not a total slam dunk, I think I could negotiate an 86% sensitivity with myself. But as I was reading the study, I was a bit shocked to find out that, in their cohort of 2,100 some odd patients who had a negative CT head, only 109, like 5% of them had an LP. Like what about the rest? Like what happened to the rest? I don't actually know who had a subarachnoid hemorrhage confirmed or not. So anyway, I think the bottom line is that we're stuck a little bit with the 6-hour time frame for the negative CT head. And otherwise, the weaknesses for the CT head can miss subarachnoid hemorrhages and other causes of thunderclap headache. Like we just said, it's unreliable at ruling out subarachnoid hemorrhage beyond 6 hours after the onset of the headache. And another thing that I came across in my review was that it's actually not valid for patients who have profound anemia or like a hematocrit less than 30%, because at that level or lower, blood is apparently isodense on the CT scan. So that's definitely a good one to keep in mind. CTA head and neck. So I think another good contender for the non-LP route in terms of strengths, it's a non-invasive study, and it's quite good actually at identifying an aneurysm that causes subarachnoid hemorrhage. In this study that I've cited here, if there was a negative CT head and a negative CTA head and neck, I was able to rule out an aneurysmal subarachnoid hemorrhage with a sensitivity of 99.4%, which with, again, very tight confidence intervals. And the other advantage with CTA head and neck is that it can help identify other causes of thunderclap headache. And then in terms of the weaknesses, contrast exposure, and unfortunately, it has not great sensitivity for aneurysms that are less than 4 millimeters and aneurysms that are at the base of the skull. So we're talking, the internal carotids, the vertebral arteries, the basilar artery, which, I mean, it's not great, but again, the majority of the aneurysms tend to appear in the circle of Willis. So we're sort of covered in that regard. The other weakness, which, I have to think about it a little bit. It's basically the high rate of incidental aneurysm findings of unknown significance. So it's an aneurysm that's not ruptured or not bleeding. Could it have caused a subarachnoid hemorrhage? We don't know. So I think I'll maybe wrap up. I'm not sure how I'm doing for time, but let's see. Basically, the take-home points from my research were negative CT head without contrast alone can reliably rule out subarachnoid hemorrhage in patients with a thunderclap headache onset less than 6 hours ago, a normal neuro exam, and a CT head being interpreted by the attending radiologist, and who are not initially presenting with neck pain, syncope, or seizure. And I've also added, even though it wasn't formally studied in the study that I talked about a bit earlier, the hematocrit should be probably equal to or above 30%, again, to try and avoid this sort of how do you call that, confusion, I guess, on the imaging. Next, a negative CTA head and neck with negative CT head without contrast can reliably rule out an aneurysmal subarachnoid hemorrhage. So I would consider this strategy when there is at least a moderate suspicion for an aneurysm. In people who LP is contraindicated, so, trauma in the low back or overlying skin infection or mass in the brain or something like that, elevated intracranial pressure. And then the incidental aneurysms, honestly, I thought about it a lot. It might even be a blessing in disguise, right? Because if we can identify that the patient has an aneurysm, there might be some interventions that we can do that are preventative to try and prevent subarachnoid hemorrhage in the future. But the other thing as well is that these patients might actually be having sentinel leaks, and this might be getting picked up with the CTA of the head and neck. And then finally, despite its weaknesses, lumbar puncture remains an important diagnostic tool in the evaluation of subarachnoid hemorrhage. So definitely we need to consider it when the suspicion for subarachnoid hemorrhage is high and when other strategies have failed to identify this diagnosis. And then again, just to reiterate the points about the interpretation, it's still a bit difficult, right? To rule it in, you have to look for possibly elevated opening pressure, elevated red blood cell count, and xanthochromia, and to rule out the aneurysmal subarachnoid hemorrhage despite the traumatic tap. The best evidence that I was able to find with regards to cutoff values include pairing it with a negative CT head without contrast, CSF count, CSF red blood cell count of less than 2,000, and no xanthochromia. And again, for this, we have to keep in mind the wide confidence intervals that were found in the study. So I think I'll open it up to questions. I think I have a few minutes left, but I want to thank you so much for your attention, and thank you again for being here this morning. I hope that you guys learned something.
Thanks, Alex. Good presentation. Any questions there's nothing in the chat. Anybody has a question? Oh, yes, Josh?
I think you're on mute, Dr. Wang.
Hey, I should be unmuted now. Do you hear me?
Yeah.
Yes, sir.
Perfect. Yeah, I definitely appreciate, getting out of LPs whenever I can. But the unfortunate thing is that whenever emergency physicians are called upon to do LPs, most of the time it will be on unstable or unwell or sometimes uncooperative patients. So it's still incumbent on us to kind of learn techniques to overcome these challenges and to kind of fit this within our usual departmental flow. So just as a slight counterbalancing argument of pushing to do an LP whenever it's like, consultant wants, and maybe we feel like Jeff Perry's window could be extended a little bit. But good talk. Thank you, Alex.
Thank you so much. To sort of address that point, there are different, we're talking about the difficult patients, and I guess you're also considering in your comment the possibility, or you're suggesting the possibility of a traumatic tap. There are different needle gauges. I think that we're not gauges, but different types and styles of needles that we can use to try and reduce the incidence of the traumatic tap. My experience with those, I think they're like non-cutting needles. My experience with those is that they're not their caliber, but their gauge is quite small, so the collection process is quite a bit more lengthy. But yeah, anyway, thank you very much for your comment. Are there any other questions or comments? I'll be happy to take them now if I've got a few minutes, or Antoine, you let me know, eh?
Yeah, I was actually wondering, you actually pulled out a study that said on day 2, the percentage. Is there anything that you were able to find between like the 6 hour and the day 2?
Yeah, previously.
Like if it's between, I don't know, like 12 hours, do you have guidelines, or it just falls there?
Yeah, I think previously the threshold was at 12 hours And they found that they had pretty good sensitivity with within a 12-hour presentation. I don't remember the specific methodological flaws in those studies, but I think at some point it was sort of given up. That 12-hour threshold was sort of found to be not as good, let's say, as the 6-hour one.
Good, thanks. All right, so if there's no other questions, well, thank you very much, Alex. Great CAT presentation. So we'll go with another CAT presentation. So Gemma Cox will be presenting on pitfalls in intubation. And after that presentation, we'll take a short break. Gemma, are you all set?
Yep, I'm all set. Do I need to be host in order to share the screen, or I can just?
No, for now, everybody has been able to just share the screen. Are you having issues?
It wasn't working, but let me just give it a try. Let's see. Let me know if you can see the slide.
Yep.
All right, and are you looking at all my presenter notes, or is it?
No, we only have this big lemon.
Excellent. Yeah, there's a lemon, exactly. Okay, so hey everybody, my name's Gemma. I'm also one of the CCFP 3 residents, and my topic today is going to be common pitfalls of intubation, particularly in the emergency department. And this is coming from a paper that was recently published in JAMA to look at what these common pitfalls are. So we're going to again start with a case, but this case, I want you to think about it as though you are in the trauma bay and you've been given a call from dispatch that you're expecting this person and they haven't arrived yet. So you actually have a bit of time to anticipate and plan how you're going to manage things. So we've got a 36-year-old guy, his name's Ed. He's coming in early in the morning of New Year's Day. He was an unrestrained passenger in a car, and there was a lateral impact to the right side. He was going super fast. And when EMS arrived, these are what his vital signs looked like. So he was tachycardic. His pressure seems like he's holding his pressure, but that's a pretty narrow pulse pressure there. And his O2 sat was low despite 4 liters. He's also got some signs of a basal skull fracture. He's super agitated. He's combative. He's trying to rip off his C-spine collar, and they're telling you all this over the phone, much more detail than they would usually give. So I want at the end of the talk here, we're going to revisit this case and talk about some of the things that we can anticipate. The objectives of my talk today are to highlight again the high-risk nature of intubation in critically ill patients, and to consider what kinds of things can go wrong and how often they are going wrong, as well as associating risk factors that we can use to predict these bad things that will happen and see whether or not this actually impacts mortality. So the first thing I'll talk about is why I chose this topic. So there's a little bit of a disclaimer here, a declaration of interest. In my past life, I did spend a few years trying to be an anesthetist, but after 3 years or so, I saw the light. However, old habits do die hard, and I tend to still think about airways in the same way. And hopefully there's a bit of value there that I can share with everyone today. Okay. So the real reason that I'm doing this topic, it's not that. The real reason is that intubation is actually one of the riskiest procedures that we do in the emergency department. And it typically involves the sickest of patients, which makes them prone to the worst of complications and the most likely to die. And if we think about why it's so dangerous, a lot of it has to do with the underlying physiological derangement, which coincidentally is also usually the reason that they're being intubated. In terms of difficult airways, historically, when we're taught about difficult airways and how to recognize them, a lot of the focus goes on to anatomical difficulty. So the A in our primary survey there, and we focus a lot on the mnemonics that will remind us of different markers. So we've got a large neck, we've got a small mouth, a large tongue, an overbite, and these things are very relevant. These are things that will make the process of putting the tube down the hole a challenge. And these patients are going to be difficult for reasons independent of where and how and why they're tubed. So regardless, in the OR, the ICU, on the ward, in the emergency department, they're going to be difficult. The second kind of airway difficulty is the physiological difficulty. And this relates far more to our B, C, D, and then sort of in brackets, don't forget your glucose, the metabolic derangements. And these people tend to be really challenging, not so much for the physical act of putting the tube down the hole, but for all the reasons that come after. And we see this most commonly in critically ill patients in the intensive care unit or in the emergency department. And then lastly, in terms of difficulty, I think we're faced with a unique challenge in the emergency department because of our environment. So there's some contextual difficulty there. If we think about comparing an operating room to the emergency department, and I'm going to ask any anesthetists in the room to not contradict me here, but in the operating room, we have usually a calm, controlled environment. The airway person has a static role, so it's a well-defined static role. And they're focusing on only one patient at a time. So they know that they've been given this one patient, and that's where they're spending all of their cognitive energy. And the teams are pretty familiar and they're pretty fixed. Versus in the emergency room, most airway crises are met with chaos. There's a very high cognitive load because the ER doctor, the role is fundamentally different. Depending on how many people are available to help, you could be both the airway manager, the team leader, and the person communicating all of this to, for example, a transfer hospital outside of your institution. So there's a lot of conflicting demands for attention, and this results in a far more dynamic role. We're frequently multitasking, and the teams are often unfamiliar. We all know that communication in the trauma bay is quite a big challenge. There's a lot of background noise, and there's always high acuity. So there's limited time available for discussion and planning. And all of these issues seem to be more present with overcrowded or potentially understaffed emergency departments. So from an ER perspective, again, this is just highlighting the novel challenges in the cohort of ER patients who present or decompensate acutely, often for unclear reasons. So the arrow that you see on the very left of the screen there, that's the pre-hospital environment. So this is with EMS. And then there's the next arrow, which represents us in the emergency department. And then finally, there's the unexpected deterioration in the ICU. And lastly, the arrow of the operating room. So there's been a thorough pre-op assessment, and the anesthetist and surgeon have come up with a plan together. So there's more risk on the left because there's a lot more uncertainty around the index pathology. So what do I mean by that? Well, for example, does this septic patient have global LV dysfunction in addition to vasoplegia? Are we about to unmask this with our induction agent? Does the trauma patient have a bilateral pneumothorax? And hopefully not, if you paid attention during any of Lori's POCUS sessions over the course of the year. And does the suspected SAH patient that Alex was just talking about, well, does that patient already have a cardiomyopathy? We don't know. So because of all these reasons, difficult airways and the likelihood of subsequent complications are far more common in the emergency department compared to the OR. And they're also more common in the intensive care unit. However, despite having good evidence to show that, we haven't had a lot of data available regarding the frequency of adverse events and what these adverse events actually are. So if we can develop a better understanding of these two things, we can establish which high priority interventions might help mitigate them. And this is what led me to the clinical question here today. So how often are bad things happening to sick patients when we intubate them? What kind of bad things are happening? And do these bad things lead to bad outcomes overall? The paper that I chose is this one. It's the Intube study. This was a huge study. It's the first of its kind, really, that looked at the frequency of adverse, major and minor adverse events in critically ill patients undergoing intubation. It had patients from across 5 continents, 29 different countries, so it was really big. It was an international multi-center prospective cohort study of consecutively intubated critically ill patients, and they were intubated in the ICU, the emergency departments, and on the ward. And by consecutively, I mean that between October and July, 2018 to 2019, every patient in hospital that underwent intubation was reported. And then a local investigator would screen those patients to see whether or not they met the study criteria. And then if they did, that case report would be collected and analyzed later on. So the patient population was critically ill. So anything wrong with your A, B, C, or D, they had to be in hospital. And the critical illness was defined as life-threatening impairment of cardiovascular, respiratory, or neurological functioning. And the exposure that was measured in this observational study was tracheal intubation. On the right side there's the flow diagram. I'm going to talk a little bit more about the inclusion and exclusion criteria, because this diagram actually doesn't specify fully what it was. So we'll talk about that in a second. In terms of the patient population, I made this little map just to show how vast the hospital sites, how broadly they covered the globe. So North America, South America, Asia, everywhere. And they ended up enrolling in Canada patients out of Toronto, but from sites that are quite comparable to those that we have here in Montreal. So TGH is, for those that don't know, TGH is a transplant sort of cancer mecca. It's where you have a lot of highly specialized and subspecialized surgeons and physicians, and they do a lot of CV surgery. The Western is similar to the Montreal Neuro. It's where you have your specialized neurology, both in and outpatient, as well as neurosurge. And then Sunnybrook, I believe Sunnybrook is the largest trauma center in Canada. And they have a massive, massive amount of resources and trauma patients that are seen there every year. So these are relatively comparable to the places that we have here in Montreal. In terms of outcomes, the authors looked in terms of their primary outcome at the incidence of major adverse events that occurred within 30 minutes from the start of intubation. And they defined major events as cardiovascular instability, so a systolic pressure that was less than 65 millimeters mercury ever, or a systolic pressure less than 90 for more than 30 minutes from the start of intubation, or a new or increased need for fluids and vasopressors. And in addition to that, they looked at severe hypoxemia measured as a peripheral SAT less than 80. They didn't specify how long the patient needed to be hypoxic for, but that was one of their outcomes. And then the incidence of actual cardiac arrest that occurred after intubation, and again, within that 30-minute time frame. In terms of the secondary outcomes, they looked at additional adverse events. And again, within 30 minutes. So these were difficult airways, which they defined as requiring more than more than two attempts. Aspiration, esophageal placement of the endotracheal tube, airway injury, complete failure, meaning the need for a surgical airway for a can't intubate, can't oxygenate situation, and pneumothorax. And then in addition to that, mortality was one of their secondary outcomes. And they looked at both ICU mortality and 28-day mortality. And these two things were calculated through a post hoc analysis, multivariate analysis. Okay, so in terms of their selection criteria, again, they captured almost 3,000 patients. They had to be critically ill as defined previously, and they had to be adults. And they needed to be intubated in the hospital in either the emergency department, the ICU, or on the ward. The exclusion criteria were anyone who was transferred in from a non-investigating site hospital, anyone who was intubated after a cardiac arrest. So there's a code blue on the floor, patients in cardiac arrest, you go place an airway, that was not included. Intubation for planned elective surgery in the operating room. So anyone who's coming in for their routine, cholecystectomy or something like that. And any patients, this is the big one, any patients who met one of the outcome parameters prior to laryngoscopy. So what this means is that if a patient was hypotensive by their definition prior to laryngoscopy, and that could mean prior or after induction, but before they actually placed the laryngoscope, they were not included. Anyone who was hypoxic prior to laryngoscopy was not included, and anybody who obviously had a cardiac arrest, as mentioned previously. So this is an interesting point in terms of the exclusion criteria, and you might ask yourself, like, why would they do that? That kind of excludes the sickest of the sick patients who we've already seen are the most likely to have these adverse events happen. And the reason is that if you had met one of your outcome parameters prior to laryngoscopy, they couldn't really say that it was a peri-intubation adverse event. So it would be difficult to establish any kind of association or subsequently causality. In terms of their analysis, I'm not much of a statistician, and the review of their methods at an in-depth level was just beyond me. But they did do a multivariate technique for their primary analysis to try and account for any confounding factors. And the study itself has been commented on in a number of different reviews that have since come out as being quite statistically sound. The fact that they were using primary statistical analysis themselves, meaning they were collecting the data rather than looking at it after the fact, at least for the initial primary outcomes, meant that there was a lot more control, and it provided a lot more precise and accurate data. So they looked at mean standard deviation of normally distributed variables, and they compared these via t-test. Chi-squared or Fisher, depending on which one was appropriate. They used both univariable and multivariable models to identify what independent variables were. And then obviously they did use a two-sided p-value less than 0.05. And so in terms of their sort of post hoc analysis, after they'd collected all their data, after they'd identified the points above, they then did a multivariable logistic regression model. And this looked at both the 28-day mortality in these patients who'd had major adverse events and those who had not had major adverse events using Kaplan-Meier estimates of survival. And then they also looked at ICU mortality. So if someone died before the 28-day limit. And then they made an association between the major events and mortality, and they adjusted this for age, sex, past medical history, sort of the reason that they were there. And some of the big ones were hematologic malignancy, heart failure, ischemic heart disease, and neoplasms. So essentially, if someone had end-stage heart failure, well, maybe they were going to die anyway from heart failure. They tried to adjust for that. That's the best I can do for the stats. Okay. So in terms of the results, spoiler alert, the key finding is that bad things happen often. It's usually to people who are very sick, and it's usually hemodynamic instability. And these bad things increase mortality. So that's in a nutshell. So in terms of the clinical process, another goal of the study was to try and identify worldwide how these people are being intubated and to get a sense of, what measures were used in a standardized way. So in terms of safety measures, they did see that a significant proportion were using checklists and protocols. An interesting one here is pre-oxygenation. So almost 80% of patients were intubated after being pre-oxygenated worldwide. In terms of rapid sequence induction, so when you have someone with a full stomach, you're in the trauma bay, you give your sedative, you give your neuromuscular agent, you don't bag them, you just go. This was done 62% of the time, and the goal of that is to prevent aspiration. And then we look here at the types of agents that were used. So we see that propofol is by far the majority, and ketamine is by far the minority. And this is an interesting point because when we'll talk about it later, in the emergency department, we typically, at least in Montreal, are more comfortable using ketamine. And so it seems kind of odd that you'd have these critically ill patients and you'd be inducing them with propofol. And I think one of the reasons for that might be that the authors of this study and many of the local investigators were in Europe. And in Europe, anesthesia plays a really large role in trauma resuscitation, in crash intubations, both on the floor and in the ER, and they also serve as intensivists. So I think that might be one of the reasons that we see that discrepancy. And then the other really interesting finding, which is quite shocking to me, is that capnography was only used 25.6% of the time to confirm placement. And this didn't vary much between countries like Canada, North America versus countries like Mexico or in South America. Across the globe, this number was fairly similar. And it's important to talk about this because this kind of sets us up for some of the outcome measures that we'll look at later. In terms of the patients, so like I said, there was nearly 3,000. Most of them were a little bit old. The majority, again, were intubated in the intensive care unit, but a good 37% were still in the emerge. And then the indication for intubation, so almost 60% of the time, it was respiratory failure and or airway obstruction. So the airway obstruction really added about 5%, but the rest of it was for respiratory failure, either hypoxemic or hypercapnic. So an issue with getting the oxygen in or an issue with ventilating. 30% of the time, it was for neurological impairment and an inability to protect the airway. And then only 10% of the time were people being intubated for hemodynamic instability. Which is really interesting because when you look at the primary outcomes and the incidence of major adverse events, by far the most common was hemodynamic instability. And this was happening in almost half of the patients. And it was happening at a rate almost the same as the incidence of major adverse events occurring at all. So when we looked at the types of adverse events, you'd see that about, I think it's written there on the slide, 40% for hemodynamic instability, almost 10% for hypoxemia, and then 3% for cardiac arrest. So that 3% number is a little bit worrisome as well. That means that 3 people out of every 100 people getting tubed actually suffers a cardiac arrest, which is concerning. And when I then compared that to the frequency of events by indication for intubation, it didn't really match up. So for example, if I have someone who's being intubated because they are unstable hemodynamically, it makes sense to me that they would become more unstable, at least initially in that 30-minute time frame after we intubate them. But we saw that the number of hemodynamic, the frequency of hemodynamic instability was high across all of the indicated different indications for intubation. And so I thought that was really interesting because it meant that it wasn't just the fact that they were already unstable to begin with. And then the second thing that I found really interesting is when they compared the adverse events with other peri-intubation adverse events, so there's secondary outcomes there, the anatomical difficulty only accounted for a minority of the adverse events. By and large, it was, again, the hemodynamic instability that was really the biggest issue. So just to go into a little bit more detail about the cardiac arrest here, luckily about, well, I think it's pretty good, at least 50% came back, 50% died. And this was actually quite interesting. In North America, 87% were able to achieve ROSC versus in Europe. And I think that that also might have to do with tendencies to call codes a little earlier elsewhere in the world and to terminate resuscitation efforts. So with cardiac arrest, even though this was only 3% of the patients, 37% of the time it was due to hemodynamic instability. And other causes that were quoted were hypoxemia and then specific disease entities. So tamponade, MIs, PEs, tension pneumos, and potassium. And I imagine that they were able to give these specifics probably because of the diagnostic tools that they had available. So if you have a POCUS, if you have a chest x-ray, if you have an ECG and a trope, you can say with certainty that this is what you think caused the patient to arrest versus the two bigger numbers up top there, the instability and hypoxemia. It's harder to delineate in some cases. But this was a bit frustrating because instability and hypoxia are consequences of all those other things that they listed. And so they're kind of lumping them in together, which I found a little bit frustrating. Okay, so what kinds of things increase the likelihood of having a major adverse event? And this was done through the post hoc analysis. So there's patient factors that are going to increase your likelihood of having something bad happen. Again, older patients, people with a full stomach, specifically a past history of CHF, hematological malignancy, or prior airway radiation or surgery. And these were all sort of taken in through the initial case report. It was an extensive form and they collected all sorts of data. And the only things that they reported in the actual paper were ones that were statistically significant. So even though they did measure differences for many other parameters, because they didn't meet statistical significance, it's included in supplemental material, but not commented on. Interestingly, none of the anatomical airway factors, difficult airway markers that we've discussed, so small mouth, big tongue, none of those things significantly independently increased the risk of having a major adverse event. And those are the things, again, that we're focusing on so much. From a physiological standpoint, hypoxemia did not independently increase the risk of having a major adverse event, respiratory failure as your indication, nor did neurological impairment. Really, the only indication that increased your risk, so pre-induction, before you do anything, the reason for intubation that was most risky was hemodynamic instability. Which I thought was really interesting. So people who needed vasopressors prior to intubation, people who were resuscitated with fluids, those parameters actually didn't have a statistical significance. At that point there is a little hard, like it was hard for me to conceptually understand. So if there's any questions at the end, we can go over it again. And then different section was iatrogenic factors. So what kinds of things are we doing that are increasing the risk of having a major adverse event? And the only one was first pass intubation failure. So the only thing that independently increased the risk of having one of the 3 adverse events was not being able to put the tube in the hole on your first attempt. Another interesting thing here is that the use of the glide scope in this study actually had an odds ratio of 1.36 for increasing the risk. Who knows, maybe that's because of the delay required to use it. Maybe they were trying direct laryngoscopy first. Maybe the people who use it more are the trainees. We don't know, but that was the finding. And this is a controversial finding. So there are certainly studies underway currently to look at this and clarify. And another really interesting thing, which it's too much data to present here, but there was no significance, no increase in likelihood of bad thing happening with IV fluids or pressors, yes or no, with specific induction agents. So whether you used propofol, midazolam, etomidate, or ketamine didn't matter. The choice of neuromuscular blockade, so whether you use rock or sucks, didn't matter. Whether you were an anesthetist or an ER doc didn't matter. And whether you were tubing in the ICU or the emergency department or the ward didn't matter. So none of those things had a significant association with the risk of adverse event. Okay, now something that did, as we said, the only thing that did was was first pass intubation failure. So then you have to look at, okay, well, what causes you to fail your first pass attempt? Like, why are you not getting it in on the first try? And then when you looked at that, there were patient factors and again, iatrogenic factors. So the patient factors, this is where the markers of a difficult airway actually did come into play. So your Mallampati score, your mouth opening, your neck mobility, whether you had a beard and whether you had a full stomach, these things actually did increase the likelihood that you were not going to be able to intubate the patient on your first attempt. From an iatrogenic perspective, in this study, based on the data that they collected, the only modifiable thing that would improve first pass success was use of the video laryngoscope. Not use, sorry, this shouldn't say use of any laryngoscope, this should say use of the video laryngoscope, and completion of your residency. So the non-modifiable factors here, the things that made you pass that tube more easily were being an anesthetist or being an attending. But again, those two things didn't have an independent impact on the adverse event likelihood. Okay, so then we go to the secondary outcomes and we see, again, as presented earlier, the esophageal intubation, multiple attempts, aspiration, dental injury, and airway injury. These were the most common, and they were happening at a much, much lower rate. And these are all the issues that relate predominantly to the airway itself. So if you have an anatomically difficult intubation, many of these things are going to be a result of that. In terms of the mortality outcomes, there was a significant association between probability of ICU mortality and 28-day mortality with the incidence of a major adverse event. So if you had a cardiac arrest, if you had an episode of severe hypoxemia, or you were hemodynamically stable within that 30-minute time frame, there was a significant association. And this was understandably most noticeable for patients who'd experienced cardiac arrest. But the second reason was patients who experienced hemodynamic instability. So this is all sort of tying into the common theme that hemodynamic instability is the major point of focus when it comes to adverse events from intubation. Okay, so in terms of our discussion, some of the good things that I liked about this study, I think it does ask a very clinically important question. And for the reasons that we've been talking about all along, you know, we focus a lot on anatomically difficult airways, but what are the adverse events that really happen more commonly and the ones that seem to matter? And as we've seen, that's hemodynamic instability. The study does seem to have good internal validity. There was primary data collection. They used multivariate analysis. The study design, I thought, was appropriate. It's an observational study, but in terms of identifying associations between an exposure and an outcome, I think that that was appropriate. And externally, this is a large heterogeneous cohort. So it's coming from many different practice settings in different geographical locations. And I think that it probably was reflective of the true incidence of these events happening, especially because we didn't see much variation depending on the geographic location in terms of what was happening most and least. However, there were a number of weaknesses. So confounding factors, it's always hard to know whether the primary outcomes that were measured were the result of intubation itself or the natural course of the disease, because sick people do get sicker. There was potential for bias. The case reporters locally who were involved in collecting the data were basing some of their conclusions on clinical judgment. So there's some subjectivity there. And there was relevant data omitted. So they didn't describe the resuscitation measures that were done prior to intubation. They would say yes or no to fluids or pressors, but they wouldn't say how much or how early. They didn't specify the doses of the induction agents. And again, these two things, I don't think they're as relevant because as we can see, neither of those two things had a significant impact statistically in terms of the risk of adverse event occurring. But the biggest gripe that I have is really the associations between primary and secondary outcomes. So they didn't really clearly go into why people were hemodynamically unstable or why they were severely hypoxic. And that I think is a bit frustrating because it's harder to establish causality there. And they also didn't comment on, like, for example, how many of these hemodynamically unstable patients were also hypoxemic. So that was a bit frustrating. In terms of the applicability, I do think that it's applicable. Again, propofol was being used much more frequently than ketamine in the study, and that doesn't really reflect our practice. And the majority of intubations were taking place in the ICU and done by anesthetists, which also doesn't affect our practice. But again, neither of these things were statistically significant in the actual incidence of adverse event. However, if you disagree with me, we can still say, does this study even matter to us? And I would argue that yes, it does. Because your confidence in your ability to manage an airway shouldn't be tied to external factors such as the availability of ketamine or the availability of a glide scope. You know, whether you're on shift here in Montreal or up north, or as many of our trainees will be outside of Canada or outside of Quebec, the availability of resources, drugs, and equipment will vary. And so I think it's important to be aware of these issues that can come up regardless of the kind of medication or the kind of equipment that was used. So here are some take-home messages and some targets. So in terms of how to improve, well, the study showed that giving fluids and pressors didn't make much of a difference in terms of the incidence of instability. And pre-oxygenating, most of the patients are already being pre-oxygenated, so it doesn't look like there's a huge room for improvement there. So really, what can we do apart from just getting better at intubating people, which, you know, comes with time and experience? I think that this really does become a discussion about the things that we know work in any critical situation. So an awareness of what can go wrong, thinking ahead and coming up with a really clear plan. And then once you've got that plan, making sure that it's vocalized well and optimized, both of which are done out loud. So trying to create a shared mental model here. And so my approach, the one I was taught, at least in my previous training, was to think about both anatomical and physiological difficulty beforehand, so before you do anything. And then think of your 3 Ps. So in terms of the patient, do they have a history of any of those factors that were associated with adverse events? So CHF was one of them. Any kind of malignancy was another one, or previous airway surgery. Those are your big 3. And I go through my checklist of, even though I have RT there, I want to check that I have my monitors, suctions, machines, airways, IVs, and drugs. I check all of those things myself before we do the 2. And then vocalize. So I tell the people around me, we are anticipating X, Y, Z, and this is where you'd bring up your considerations. And I think that this is especially important in the ER, where you've got so many people doing so many different things at once. It's easy to lose track. So vocalizing it out loud is really important, and optimizing it out loud. So I say, plan A, I'm going to do X, Y, Z in hopes of improving these things that we've talked about. Plan B, if this doesn't work, and plan C, my rescue. And if you vocalize all three of those things out loud, hopefully it'll be easier to get everyone on the same page in the event that something bad goes on. So what are the take-home messages? A lot of information here. Adverse events are very common. Bad things happen often to sick people. The most bad thing is hemodynamic instability. And remember your ABCs. So anatomical difficulty, which is your airway, versus physiological, which is your breathing, circulation, and disability. And hopefully, if you keep those three things in mind, stuff will get better eventually. Okay. So back to our case here. I know we're a little bit over time. I've got 4 minutes left technically. If we think about this guy and he's not right in front of us, you know, if he's right in front of us, we go into our ATLS primary survey. But if he's not right in front of us yet, we have some time to think. The patient, we're going to consider what about this patient? If anyone's still here and listening, does anyone have any suggestions on what kind of anatomical or physiological issues we might encounter?
So he's going to be first, he looks a bit overweight, so that's anatomically it's going to be a bit hard. He was a trauma, so he'll possibly be in a C-collar.
Yep.
In that context, video laryngoscope might be a good idea for the first passage.
Mm-hmm.
And if I recall, his vital signs were a bit worrisome too.
Yeah, so he was, his SAT was 93% on 3 liters. He had a respirate of 27. Blood pressure was 133 on 100, and heart rate was 134, I think.
So, yeah, and also agitated. So I would possibly medicate him to try to calm him down first, so we can go through our full assessment to see trauma. Does he have like a pneumothorax that could explain?
Exactly.
And then most likely we'll end up going and having to intubate him.
Perfect. Yeah. So those are all the considerations. And then the next step is important to think about as well. So it's your conflicts. So for traumas, you were saying you want to use the laryngoscope, which is absolutely correct. He's in a C-spine collar, limited neck mobility. Again, that's going to make it harder. But on top of that, he's full stomach. So he's high risk of aspiration. These patients would traditionally be managed with an RSI, a rapid sequence induction. But is that the best method to use for someone who we think has an anatomically difficult airway? No. So it's important to be aware of those two conflicts so that you can then choose the one that is most applicable. So that's an example of one of the conflicts. And then in terms of what you'd say out loud, well, plan A, it's exactly what you did. So plan A, I'm going to use a laryngoscope. I'm going to have suction ready. I'm going to have manual inline. This, and this. And then plan B, what could you do to help if that wasn't working? So you've got manual inline there and you cannot get a view with your laryngoscope. What's something else you can do?
So bougie is always something that can help us. And there is a school of thought that say you should try if you expect a first attempt, that's going to be hard.
Exactly.
Go in the kitchen sink and just go with all the tools you can get. And
exactly. And then plan C, your Hail Mary, you're going to have surgical equipment available. But something else you can do, and this is again quite a controversial topic, there's not a lot of evidence for manual inline stabilization. So if you're really struggling, you can take that off and go without. And I'm going to be eaten alive for saying that, but it's a true fact. Okay, yeah, so that's exactly right. That's an example of how you could approach a case before they arrive and think through some of the issues you might encounter. So are there any questions? And does anybody know why I've got lemons all over my slide?
For airway?
Yeah, exactly. Mnemonic, lemon mnemonic. Any other questions? It's pretty dense.
So I see in the chat there is basically so Dr. Nemeth, who said that he always marks for those who haven't worked with Dr. Nemeth, so he always marked the site of the Craig.
Yes, I agree. Actually, that's amazing. Yes.
Especially with that guy, I think in panicking, it's going to be a hard
tough to do.
So yes, that's always a good thing. And as he says, it prepares the whole team that we could go down that road. And then Dr. Doyle says that always use jaw lift in the inline stabilization. And Alex being a good fellow resident.
Perfect.
All right, great presentation. I don't know if there's any other questions.
No, excellent.
No?
Thanks, guys.
All right, then we'll take a break, and we actually, because we're in time, we can have a 15-minute break.
Fantastic.
All right, so see everybody at 10:15.
I have been writing about what patriarchy does to us men, what patriarchy does to our relationship to ourselves, what patriarchy does to relationships for over 30 years. This new book is about that, and it's also
All right. So it's been around 15 minutes. I hope you guys are now ready to restart and comfortable, having your coffee, and ready for another great CAT topic presentation by Nadia Omri, who is presenting on ketamine in severe agitation.
All right, let me share my screen. Can you guys see? Is it good? Perfect. All right. So bear with me. I am post-call. So if I'm a little delirious, that is why. So today I'll be talking about severe agitation in the emergency department, a vitamin K deficiency. So first, I'll just introduce a case that's probably very common and very known to all of you. A 26-year-old man found outside a local bar, brought in by police with severe agitation. He's physically and verbally aggressive towards staff, and a code white is called. So let's just quickly review what physical restraints and what's proper positioning of physical restraints before we go on. So that means one arm up and then one down, and then the head should be raised about 30 degrees. And the restraint should be soft. That way the patient doesn't kind of sit up and has less risk of aspirating. All right, now that we got that out of the way. So what would you like to give this patient to chemically restrain them? People can just write in the chat. I see some benzos, Haldol Advans, Zyprexia. Perfect, lots of different thoughts. Right. So next we'll just go on to categorizing agitation. So mild agitation would be someone that's agitated but cooperative, someone that's moderately agitated, someone that's disruptive but without any danger to themselves or to the staff, and someone that's severely agitated, someone that's in excited delirium, plus or minus a danger to themselves or to the staff. So what is excited delirium? That's someone who's extremely agitated and aggressive. They have extreme physical strength, like the old lady that can lift a car when she's severely agitated. They're incoherent, they have inattention, they can be tachycardic, tachypnic, febrile or hyperthermic, and diaphoretic. And this could be quite the problem because they can sometimes or oftentimes be acidemic. They can go into rhabdo. They can cause themselves to have secondary trauma, and it can lead to MI and sudden death. So just a few causes of organic causes of agitation to keep in mind when someone comes in, things that we want to rule out and be aware of. So hyperglycemia, thyroid storm or myxedema, any CNS infection, any intox or withdrawal, delirium tremens, and then in terms of traumatic, any intracranial hemorrhage, diffuse axonal injury. It could be hypoxic, hypercarbic, and hypo or hypernatremic. They can be in status or postictal, just delirium, subarachnoid, or stroke, and many more. In terms of psychiatric cause, they have depression, bipolar, postpartum psychosis, substance psychosis, brief psychotic episode, delusional disorder, all of those things can cause severe agitation. So a quick approach to the severely agitated patient. First of all, the safety of everyone is number one. Code white should be called, have extra people, have extra help. You can try verbal de-escalation, unlikely to work in someone that's that severely agitated and may not be safe, but if it is and you're able to do it, then might as well try. Physically restrain the patient and then chemically restrain the patient would be the next step. And the chemical restraint part is the part that we're going to talk about most today. So why do we use a chemical restraint? We can have a safe assessment of the patient and to rule out those dangerous organic causes or complication of excited delirium to make sure that we can stabilize them and then monitor them appropriately. So all severely agitated patients should be seen in the recess rooms, and then once calm, put them on the monitors, because typically if they're that agitated, it's unsafe to do so at the moment. And then put them on oximetry and capnography, get IV access, and then do as you would usually, your POCUS, your blood work, urine, CT head, urine tox. Controversial, but I put it there in case the in your institution, the psychiatrist likes to have that. And then continue to monitor them, especially after chemical sedation. And then should you need to intubate them, it would be safer to avoid sucks if they're in agitated delirium for the risk of hyperkalemia. So what do we look for in a chemical restraint? So something that can be given IM is the safest route, because getting an IV in these patients is unsafe for the staff and yourself. Something that acts quickly, something that has low adverse effects, and the duration of sedation that's, I guess, best for that patient. So if you want to be able to discharge them home after or get them to see psych, something to keep in mind. So let's talk about psychopharmacology of agitation. So most of you probably seen this algorithm. It's in Tamponade and in Rosen's. It's a 2012. It's from 2012, so quite outdated, and it goes through, if they're agitated due to intox, delirium, and then goes down your pathways. And things have changed since then. So here is the 2020 version of that same best practice and evaluation treatment of agitation group. So here's the drugs now that they have on their paper. So we'll go through it quickly and keeping in mind the time of onset, as well as the common / side effects or adverse reactions. So Haldol for the severely agitated patient, it's 5 milligrams IM with a time of onset of 30 minutes with highest risk of EPS. And one of the EPS could be dystonia, meaning they can have laryngospasms as well. And it can increase your QTC and then may lower your seizure threshold. So that's one to keep in mind. The other one, I see some people mention Zyprexia. So 10 milligrams for the severely agitated takes about 15 to 45 minutes. The issue with it is that if they're not adequately sedated after that, you cannot use benzos within an hour just due to the risk of bradycardia and hypotension. We're going to skip over risperidone just mainly because it's not, there's no dose for the severely agitated person, and it's oral. So going to the benzos, the Ativan is PO, and as you guys know, intramuscular Ativan is poorly absorbed, even though often used, and usually takes IM about 20 to 30 minutes compared to the IV, which is about 15, but again, poorly absorbed IM, and we're looking for something that's IM. In terms of the Versed, the midazolam for the severely agitated, 10 to 5, and takes about 15 minutes. And then the ketamine. So as we saw, the ketamine in 2012, there was no ketamine in 2012 version, and now it's here. So it's 5 milligrams per kilogram IM with the onset about what they quote at 3 minutes, with the increased risk of emergence reactions, bronchorrhea, laryngospasms, and may increase the rate of intubation, sorry. So quickly talking about ketamine, it's a non-competitive MD receptor antagonist, causes dissociation, analgesia, and amnesia, commonly used for procedural sedation and intubation in the emergency department. This is from the ACEP 2011 clinical practice guideline for ketamine. And what I found interesting is that they do write the typical duration of the dissociation, and as well as the typical time from dose to discharge. So important to know how long the ketamine is going to last and when I could discharge this or disposition this patient. So for the IM, it's about 60 to 140 minutes. And then the duration of the dissociation, about 20 to 30 minutes, with the peak concentration and clinical onset at what's quoted here as 5 minutes. So contraindication. So hypersensitivity in conditions that increase your BP, the Canadian labeling does write that if the patient has a history of CVA, severe cardiac decompensation, surgery to the larynx, pharynx, and bronchial tree, it's a contraindication unless they have adequate muscle relaxant, just because the risk of bronchorrhea and spasm. And in the ACEP ketamine guideline, they mention that if someone is less than 3 months old or they're known or suspected schizophrenia, then it should be avoided. Oops. They also go on to have all these relative contraindications, glaucoma, porphyria, thyroid disorder, masses. I'm just going to leave that here. All right, so adverse effects that are significant: laryngospasms, apnea, respiratory distress, depression, sorry, tachycardia, sorry, and elevated BP and emergence reaction. Now, quickly, ketamine in pregnancy. Should you have a pregnant patient, could you use ketamine? Well, it does cross the placenta. It is for the teratogenicities, we don't have any available human data, but they found that in 2 monkey studies that there is an association with neuroapoptosis. And then in terms of neonatal depression, there is a dose-related depression and decreased Abgor scars in some studies, whereas some studies showed that it did not affect those. And I've mentioned the aponeurosis. In those studies, the induction dose was 10 milligrams per kilograms with an infusion of 10 to 80 milligram per kilogram per hour for 5 hours. So quite high doses that we wouldn't use. And they also noted that there were some dose-dependent uterine contractions. Some study, again, showed this and some did not, and increased maternal heart rate and blood pressure. So if someone does have pre-existing hypertension or preeclampsia, eclampsia shouldn't be used in those patients. So all in all, if they're pregnant, it is okay to use if they're hemodynamically unstable. If not, another option could be used. So now let's go on to a few studies. So Lin and al. Is a 2001 study called The Efficacy of Ketamine in Initial Control for Acute Agitation in the Emergency Department, a randomized controlled study or randomization study. It was an open label prospective study, single institution, 93 patients, where they compare the efficacy and the safety of ketamine versus Haldol and Ativan for the acute agitated patient. For them, they used 4 milligrams per kilogram of IM ketamine or 1 milligram per kilogram IV compared to Haldol 5 to 10 IM or IV or 1 to 2 IM or IV. So this was the data was collected in 2018, and they excluded all the patients with the following contraindications to ketamine. So they've said pregnancy, schizophrenia, angina, uncontrolled hypertension, heart failure, glaucoma, thyroid disorder. But later on in the study, because it's very difficult to obtain a history in a severely agitated patient, that they found out that half of the patients that got ketamine had a psych history. So their primary outcome was a RAS less 1 or less within 5 minutes, and they showed that 20%, 22% of the ketamine group obtained that versus 0% of the Haldol and Ativan group. And their secondary outcome was a RAS 1 or less within 15 minutes. And it was 66% versus 7 for the ketamine group. And the mean to adequate sedation being a RAS again of 1 or less, was 15 for ketamine and 35 for Haldol and Ativan. And then they looked at the safety. So they looked at hypoxia, meaning less than 92%, and they saw that for ketamine, it was 21 versus 10, but it was not statistically significant. And most people, it resolved quite quickly. And there was 1 intubation in both groups, and unfortunately 1 death in the Haldol and Ativan group. So there was lots of pros and cons to using different drugs in the severely agitated patient. So I wanted to know, is ketamine a safe and effective treatment compared to Haldol and midazolam, given that midazolam can be given IM and faster, which led me to the RAC study, the Rapid Agitation Control with Ketamine in Emergency Department, a blind randomized controlled trial, which was a study published in 2021. Their research question was the following: which more rapidly achieves adequate sedation? Ketamine, they used 5 milligrams per kilogram IM, or midaz 5 milligrams plus Haldol IM. So in terms of their study design, it was done in Vancouver at St. Paul's Hospital. They used a 1-to-1 randomized trial. It was partially blinded, and I say that mainly because the nurse who drew up the meds was unblinded, but she had no other implication in the data collection. They screened 308 patients between June 30th to March 13th of 2020, and enrolled only 80. So those patients were only screened during daytime hours. I say daytime, between 8 to midnight by trained staff. So their outcomes was time in minutes from medication administration to adequate sedation, which was a RAS of more equal of -1. The secondary outcomes was the need for rescue medication, and that was either benzo antipsychotics or any other sedative that was chosen by the physician. And the occurrence of pre-specified adverse events, apnea treated with BMB, laryngospasms, the need for oxygen, dystonia, and the occurrence of NMS within 72 hours. So in terms of their population, their inclusion criteria was adults aged 19 to 60. They had to have severe psychomotor agitation measured by a RAS of equal or more +3. They excluded people that were previously enrolled in the study, that were in police custody, pregnant, or breastfeeding, hypersensitivity or intolerance to the aforementioned medication. And if they had the following comorbidities: glaucoma, COPD, pulmonary insufficiency, cardiac decompensation, hypertension, CVA, Parkinson, and severe depressive state or spastic disease. So here, just a quick, if anyone does not know what the RAS scale I've been referring to. So they enrolled people that were very a 3, so very agitated, and then they were hoping for a minus, anything better than a -1, which was drowsy. So the study treatments, so they randomized the patients to the ketamine group, which was 5 milligrams IM. So they used multiple syringe because it was 4 mil, and they can only give 4 milligrams per IM sites, which ends up being a lot of syringes and a lot of injections, versus the midazolam group, which was 5 of midaz and 5 of Haldol, which they put in 1 single syringe. So the monitoring in both groups was the same. They documented the RAS every 5 minutes until their primary endpoint, or until 30 minutes. And they were on monitors for 30 or more minutes after medication administration. or until medically cleared or behaviorally cleared by the doctor. They all had the same investigations, meaning a CBC, lights, ethanol ASA, salicylate, and ECG. And the adverse events were recorded until the discharge from the emergency department or the hospital. So in terms of their results, so like I mentioned, 308 were eligible, but they only randomized 81, but only ended up having 80. And they either went into the Madaz Haldol group or the ketamine group. They lost in the Haldol Madaz group. They did not lose anyone to follow up. And then they did lose someone to follow up in the ketamine group, unfortunately. So in terms of the demographics, 68% were men with a median age of 35. In terms of the, if you look at the initial RAS score, you can see that in the ketamine group, 4+, there was 25 compared to 18 in the Haldol Madaz group, which is interesting. And there was more males in the ketamine group versus the Haldol Madaz group. So in terms of their primary outcomes, the time from medication to a RAS of -1, the median time for ketamine was 5.8 minutes. And then for the Haldol Madaz group was 14.7 minutes with a difference of -0.8 minute. So clearly the ketamine group is much shorter, and there was a greater proportion of patients that actually had adequate sedation in the ketamine group versus the Madaz and Haldol group. As for the secondary outcomes, which was one of them being the need for rescue medication, it's about similar in both groups. So both of them actually didn't require anything until the 15-minute mark, 2 in the ketamine, 3 in the Madaz, but roughly about the same. In terms of the occurrence of pre-specified adverse events, so apnea requiring BMV for less than 5 minutes, there was 1 more in the ketamine group, and then requiring supplemental oxygen was equal in both groups. Laryngospasm, which was fixed with jaw thrust and airway positioning, 1 in the ketamine group. And then dystonia, again, 1 in the ketamine group. No one needed intubation and no one was admitted to the ICU. So it seems that there's obviously a bit more adverse events with the ketamine group than the Madaz Haldol group. But the serious adverse events, there is no statistically difference between the two. So this is kind of just a little graph comparing just everything that we talked about. So the time to -1 was much better in the ketamine than Haldol. The need for rescue medication was 13% versus 15, and the adverse event was 12.5 compared to 5. So now critically appraising this article, was the patient randomized? Yes, they were. Was the randomization process concealed? Yes. But like I mentioned, one of the nurses was unblinded, and she's the one who prepared the medication, but it was blinded to the study staff, the investigation research assistant, and the nurse only gave the medication. The only other thing that could have led to unblinding was the fact that the ketamine group had so much in needles and injections versus the Haldol and Madaz only had 1. So it could be biased that way. For the patient analyzed in the groups that they were randomized, yes, were 2 groups similar in respect to demographics and prognostic factor. I wrote no, mainly because there was more males in the ketamine group versus the Haldol group, and there was imbalance with the initial agitation score, where there's 64 in the ketamine for a RAS of +4 versus 45. And were all participants unaware of the group allocation? Yes, but as I mentioned, there was a potential for unblinding, but participants wouldn't really know that. Mainly it's the by participants, I mean the patients, mainly the staff would. All groups were treated equally. Yes, they all had the same monitoring. Follow-up was complete for more than 80%. Yes. There, as I mentioned earlier, one of the secondary outcomes was looking at the occurrence of NMS within the 72 hours, where they mentioned in the article that they were going to do that through chart reviews and phone calls, but there was no results reported for that. So who's to know what happened to that? And in terms of the treatment effect was large enough to be statistically significant. No, unfortunately, they had to stop the research due to COVID-19. So they didn't obtain power. To obtain power, they needed 160 patients, so 83 per group, and they only had 80 in total. So that was unfortunate. So I was just interested in their appendices. They added what the research assistant guessed for the treatment groups, which I thought was going to be much different, mainly because ketamine, there's much more injections, and then midazolam is only one. But this is what the research assistant, what their guesses were, which I thought was interesting. So in terms of strength, it was a well thought out RTC. It did provide important information about ketamine for severe agitation, since we don't have that many great research on it. And there is statistically significant and clinically relevant shorter RASS of -1 with the ketamine, which is important. In terms of limitations, there is insufficient power to assess the potential differences in safety. There was the potential of unblinding, like I mentioned. It was only one center. It was a convenience sample, mainly because they only enrolled people from 8 to midnight. And the rescue medication, it was at the discretion of the doctor in charge, and it didn't report what it was. And, you know, if there was unblinding, would it affect their choice? Would they know that the patient got 3 injections, meaning it was likely ketamine? Would that affect what they used? Who's to know? So my thoughts, I was, wondering, it's a weight-based ketamine, but how did they weight the patient when they're so severely agitated? Was it just like an eyeball weight? I'm not sure. The article didn't mention, and they didn't report the third secondary outcome of the occurrence of NMS within 72 hours. And I would be curious to know the duration of sedation for both groups, and did it delay their disposition to home, to psych, to somewhere else? So I know I talked really quick, but my clinical take points from this is that ketamine is super fast and very good at managing severe agitation. There is some adverse effects, so it's important to keep in mind the population that you're going to use it in. And just for safety for other people, it's important that you have the adequate concentration for only having one IM injection instead of having multiple. And kind of a pick the lesser evil, meaning that, ketamine versus Haldol and Midaz, they both have their adverse events and profile. And it'd be important to put everyone on the cardiac monitor with severe agitation, receiving sedation. And that's all. Thanks for tuning in.
Thanks so much, Nadia. I had a quick question.
Sure.
My question, I might have missed you talking about it, but did you comment on how they got consent for the people to do this?
No, that I don't know how they got enrolled. It was just, they mentioned that the research assistants enrolled them, but how said enrollment process is, I can't comment on that.
Interesting. Or like whether these were like involuntary agitation to like chemical restraints versus something to help calm them down that they were consenting to. I just thought it was interesting.
No, these were definitely chemically restraints. Like they were very agitated patients.
I wonder how they got consent.
I believe, if I remember correctly, in their ethics, they got like approved for this, but I can get with the details.
Oh, cool. Thanks.
All right. Is there any other questions? All right. Then thank you, Nadia. Great presentation. We'll go with another resident today, but we're switching from the CCFP to the FRCP. So today, Dana is going to do her grand round on simulation methods.
Hi, everyone. I'll see if I can share. Okay. Is it sharing? Okay, perfect. So good morning, everyone. My name is Dana Arab. I'm one of the PGY3s. And today I'm going to speak about, like, it's an introduction for simulation and how simulation came to be and what's method of simulation and simulation in the literature. So I hope you guys enjoy it. So today I'm going to talk about what is the definition of simulation, history of simulation, why and what's the purpose of doing all of these simulation and why integrating it in our curriculum, type of simulation that we have, and how in the end I'm going to speak briefly about how to create a simulation scenario for all the junior residents who haven't had a chance to create or be participate in creating a simulation yet. So as we know, the medical education has been rapidly evolving, and simulation is part of the medical education field, and it's providing all the educator with a novel way to deliver medical education in multiple fields and in a lot of creative ways. It's an artificial representation of a real-world event to achieve educational goals through experiential learning. And for designing an effective simulation scenario, it requires careful planning, and the steps to creating a simulation can be broken into multiple steps that I'm going to talk about it in the end. So a bit of a history of how simulation came to be. It's actually started back in the 1950s, where the first mannequin was used to teach airway and resistive skills, was developed by two anesthesiologists, Dr. Peter Safar, which was from the USA, and Dr. Bjorn Lind from Norway. And Dr. Lind developed what is called a rhesus Annie, which I thought it was interesting to see because apparently it was featured in a lot of simulation at the time. It was like in drowning patients and CPRs and all of these things. And this is how it looked like before. Very basics. And it actually fits into that bag. Okay. And then 10 years later, Dr. Stefan Abrahamson from the United States presented the advantage of training anesthesiologists with a full-scale computer-controlled human patient simulators. And then toward the 1980s, two teams of anesthesiologists, as you can see, most of this was developed by anesthesiologists, and they are like basically the first people who started doing that is them and the military and aviation at the time, but I'm just going to be stuck. I'm just going to be saying about the medical part of it. And then, yeah, we had two teams, one from the University of Florida and one from Stanford. And then they developed a realistic mannequin simulation where they combined engineering skills and the idea of using simulation in education for team training and with the aim of improving patient safety. From this, they result in what's called like an interactive, realistic patient simulator that was replicating the human responses to various physiological and pharmacological interaction. And this is what was the base of our current simulation, where we have more high fidelity simulation mannequins where they interact with us. We can let them speak now, and they can have changes in the blood pressure, heart rate, and even if some mannequins are used to teach the students how to listen to normal heart sounds, or if there's murmurs, or if there is any change in the breathing, and even like pupil dilations and constriction. Okay. So what's the purpose of having a simulation, and why are we integrating it now into our medical education? So they are designed to assess, to educate, and help learners to self-identify gaps in their understanding of materials or application of their knowledge. So it's interesting to see people apply all of their knowledge in a safe and a safe environment where they can actually perform it without risking the patient's safety. It's used to address as well patient safety issues and clinical cases. It's used as well in teamwork opportunities. It can be used for communication and also for procedural competencies and leadership skills. I don't know. In the simulation, the scenarios that we are designing must include the consideration of what type of resources that you have. Like if you want high fidelity, low fidelity mannequins, like you can use either mannequins, you can use real life patient that can like basically actors, or if what kind of equipment do you have? Do you have computers? Do you have papers? That all have to be in consideration of what you have to do in the simulation. And they should be designed to address a perceived knowledge or a performance gap. The finished scenario should take place in a safe and non-judgmental setting. That's very important for the junior learners or any learners, that it's a safe and non-judgmental setting. So there isn't any real like assessment, or it's not going to be taken into while they practice in their hospitals. It's a non-judgmental place that they can safely practice and maybe make mistakes at the time. But like, and the most important part is to like practice and learn from the scenarios that they are going through. We have multiple scenarios. If a scenario is used for assessment, it should be at the level of the patient learner. It should be at the level of the learner and the learner should be performed well in it for the assessment. However, if it was for the purpose of education, then it should be at a challenging level, so it can give growth for the learner in that scenario. And the ultimate goal from all of this is that we have to provide clinical practice, improve the clinical practice, and as well as patient safety. It's much better to have a practice on mannequins and all these scenarios instead of really just practicing it like on real patients. So I'm gonna go through some of systematic reviews that was done for simulation in literature. I found this study that was the utility of simulation in medical education. What is the evidence? But this is a bit of an old study, and it's done in 2009. But they collected a lot of studies that they were acquiring from previous years. And they had collected 113 articles in this review. They had multiple, conducted midline research, and they used multiple headlines that included simulation in education, mannequin simulators, and partial task simulator. And they included studies for graduate medical education and also for residents in this. And in this article as well, they looked or reviewed the articles that was done by the fields of anesthesia, obstetric, emergency, and in surgery. And they found that the simulation-based training was demonstrated to lead to clinical improvement in multiple areas of simulation and research. One of them is that resident who trained, this is from the surgery part of the review, that resident trained on laparoscopic surgery simulators showed improvement in their procedural performance in the operating room. And the other study showed that residents trained on simulators were more likely to adhere to the advanced cardiac life support protocols than those who received standard training for cardiac arrest patients. And they also showed improvement in medical knowledge in assessing residents and students for comfort in their procedures, and also improvement in the performance during retesting in simulated scenarios. And the simulation has also been shown to be a reliable tool for assessing learners and for teaching topics such as teamwork and communication. So there was multiple, and one of them, I'm gonna mention it later, multiple studies that showed even simulations for communication skills, either between colleagues or between patients and residents, have been shown through simulation that it can be improved. And multiple studies have demonstrated the effectiveness of simulation in the teaching of basic science and clinical knowledge, procedural skills, teamwork, and communication, as well as assessment of the at the undergraduate and graduate medical education levels. This is another study as well that's did systematic review, but this is a bit newer than the other one. Is in 2011, and it's simulation in medical school education, but this is a review for emergency medicine. And in this study, they mentioned that there was a study that was done for 5 years, from 2003 to 2008, and it was on the growth of simulation training in the emergency medicine residency programs. And it showed that there was an increase of utilizing of the emergency of the simulators in our in the training of residents. And from they studied like 134 residency programs that participated in the study, and they found that 91% of the programs use some kind of simulation equipment to train their residents. Notably, 43% of program documented that they use more than 10 hours of simulation per resident. And the program used simulation as a tool for teaching and assessing the resident and for training them in the areas of professionalism and the teamwork. And simulation in internal medicine has proved useful in both academic and professional spheres of residency education. There is another review that was done in 2006 and also support this type of simulation training in emergency medicine, and it documents that programs using these methods showed significant improvement. So, and they found the significant improvement to be in the airway management in the emergency settings. They found that there is like improvement in the surgical airway management as well, and significant improvement in ethics application and teamwork performance. There is another study that was also mentioned. It was conducted in 2009, where they acquired 28 residents and were educated about critical resuscitation procedures by using simulators. And the evaluation of this process consisted of 2 stages of self-assessment of the knowledge and the clinical skills that they acquired during this training. They assessed the residents the first time, or the first stage is immediately after 8 hours of simulation, and the second stage was done after 3 months, and it showed that the residents had improvement immediately and continued to demonstrate benefits after 3 months of wash-off period. And this is in this study, they used the validity of the self-assessment questionnaire was assessed by evaluating participant skill acquisition through an objective structured clinical examination station. And they found that there was a statistical significant improvement in participants' ratings of both knowledge and the clinical skills during the 3 self-assessment period. And the participant year of postgrad training influenced their self-assessment of knowledge. They also found that the 3-month follow-up for the junior residents, they showed consistent improvement from their baseline. However, they had regressed from their post-training measures. However, for a senior level resident, which was interesting, they showed continued to have further increase in their assessment of both the clinical skills and the knowledge beyond the simulation-based training course. So the conclusion from this study that they did was that there was a significant improvement in self-assessed theoretical knowledge, and the procedural skills competence for residents can be achieved through participation in simulation-based station courses, and gains in perceived competence appear to be stable over time, with senior learners gaining further confidence at the 3-month follow-up. this is what I was talking about when I mentioned that also simulation is very important to use when used for communication, especially between patients and doctors or physician. This is a study that was done in 2022, actually in May of 2022, and it's managing acute decompensation and life-limiting illness. It's a novel simulation curriculum. The research objective of this one is to implement a novel virtual simulation curriculum to teach clinical management and serious illness communication skills for patients with serious illness. And it was done to explore internal medicine and emergency medicine residents' perspective regarding the barriers to discuss the goals of care conversations in an acute care setting. What they did was they invited the resident to watch a 20-minute communication skill detected video, and then they participated in a 60-minute simulation exercise, followed by a 60-minute semi-structured group interview, both via Zoom, and it was led by a faculty facilitator. The participant interviewed the simulated spouse of a patient with advanced cancer presenting to the emergency department with progressive symptoms and functional decline. And the simulation was divided into 3 sequential 20-minute sections, allowing each participant to lead a third of the encounter. Afterward, the participants were asked about their perspective related to caring for a seriously ill patient ill patients in this settings. So what they found is, with the qualitative data from the group interviews, it was revealed that there was 3 perceived barriers in the communication in an acute care settings. One of them is limited patient and family prognostic awareness, environmental barriers such as inadequate physical space and time, and the lack of real-time feedback from a faculty around communication skills. All participants found that specific phrasing in the detected video to be very helpful. And the conclusion was that novel simulation curriculum was well perceived by participants, and this study identified the 3 important perceived barriers of communication. So it is a very interesting way of teaching other residents the communication skills that needs to be done, especially in end-of-life care or in difficult situation in emergency medicine. So now I'm going to talk about the type of simulation and what type of simulation that we have. Type of simulation, we have several types. We can either divide it into like high fidelity, very advanced, or very advanced simulation, or we can do it as a low fidelity with just like standardized patient, which is what we used to do with like simulated actors, or just one patient, and then we can hand them like papers to change the vital signs and lab investigations. However, it's much more than that. We have now, other than standardized patient, we have partial task trainers. We have mannequins with high fidelity that can speak, they can change the vital signs, they can change their like pupils, maybe sometimes make them more sweaty, can have more respiration, like tachypneic and tachycardic. We can have screen-based computer simulators where the residents or the learners are just in front of computers and learning through that, but interactively. And then we have now apparently virtual reality simulators, which I wish I'm doing that, but like I haven't done that yet. But virtual reality simulators are actually, it's being conducted in other centers. And I have an actual a cool study that was done in 2022 as well. It's comparative effectiveness of virtual reality versus the e-module on training of donning and doffing. And they did this study just to have ideas, because like it's during the pandemic, we had a lot of donning and doffing trainings that was done. So this study was done to see if the virtual reality training is much better than the e-module like online training. And it's a randomized simulation-based educational study. So what they did is it's a prospective randomized open blinded controlled trial. It was used to determine the difference in donning and doffing performance after virtual reality and e-module PPE training among medical staff and medical students at a single institution. The primary outcome that they were looking for was donning and doffing performance with real PPE assessed using a 64-point checklist. So they have a checklist that they went through it. And the secondary outcome for that was participants' preparedness and confidence level after the training. And actually, it looks like really cool if we have this gadget and like we're just like trying to wear our PPEs. I think it was not, I want to try it as well. So what they found is that there was a 54 participants, and it's consisting of medical students and emergency medicine and ENT residents. And they found that the virtual reality group performed better than the control in the overall PPE score, but it was not statistically significant. And virtual reality participant also reported higher level of preparedness and confidence after the training. And in the residents as a subgroup achieved the highest increase after the virtual reality training compared to their counterpart in the controlled training group. So in conclusion, they found there was virtual reality training was found to be non-inferior to the e-module for asynchronous PPE training, but these results suggest that particular residents may benefit most from virtual reality PPE training. And the virtual reality participant felt more confident and prepared to don and doff PPE after training compared to e-module participants. In this study, they didn't mention any limitation or anything, but I think from our own perspective, I think virtual reality is a nice and like a new way of teaching, and I hope it becomes like more popular, but I think it's mostly costly, and it will need more fundings and more it's just like I think it's going to be costly, but hopefully if it gets widely spread, then it can be available for everyone. So the last thing I'm going to talk about is creating a simulation scenario, like for our junior residents and for anyone who haven't created simulation scenarios. So you have to have a scenario that must be approached systematically. You have to have your intended outcomes. You have to have a context of your simulation, as well as the goals and objective. And other than that, you have to identify who are your learners and what their level of education, what their level of training is, followed by what's the desired outcome that you want them to learn or to gain from all of this. And also it will include the knowledge and behavior the learner is to acquire after participation in the simulation. So you have to have all of these in mind before you start applying or like creating a scenario. So how to prepare? The preparation will include that you have a case. Like initially you just have a case that you have in mind, or a topic, and then you create a case stem, which is the initial information that you want the learners to know. Then after the case stem, you want to have a flow of how your case is gonna go through. So it starts like you have a basic start of your case, and then every time that something happens, there's a counter action, or there's a reaction to anything that was done in the initial steps. You have to have a role in the script. You have to have who's participating in your scenario. Do you need nurses? Do you need RTs? Or it's just the resident that's gonna divide themselves? You need to know what's your resources. You need to have a pre-briefing and a debriefing. And a debriefing is a very important step in the simulation. I'm going to talk about it briefly later. And you have to have a dry run. We have to go, like, whoever had a simulation scenario to perform, always we do a dry run, like a day before or 2 days before that. We run it through the whole scenario, see if there is any gaps of knowledge, see if there is anything to be changed, and see and anticipate how the learners will react into certain situations, and how to avoid not letting the learners like just deviate from what you want them to learn. So after the outcomes have been set, determine your context, including the type of case, patient, fidelity, equipment, and supplies, then construct the goals and objectives. And as I said, you have to identify the relevant teaching points the learner should acquire and remember. And goals are what you want the learners to learn, and your objectives are what you expect the learner to be able to do at the end of the simulation. So I added my own, last year I did the simulation, and I added, this is how the template for performing a simulation look like. Anyone who wants it, I can just send it to them. So it's a very standardized template that we use it in the MMU@C. You have to have your goal. I don't know if you can see my my pointer, but you have to have your goals set, and you have to know what's your goals for the simulation is. You have to have your clinical vignette, which is like who's the patient and what they're coming from, what their presentation is, and then it's divided into these steps. So you have to know what's your resources and what do you want to use. Do you want to use a mannequin? Do you want to use a computer or a standardized patient? So you have to adjust all of that for your learners. You have and you have to have like the environment and what do you want them to perform. Then you have to have what's required. Do you need monitors? Do you need like monitors? Do you need blood pressure cuffs? What we have in the MU@C is usually we have our iPad, and it changes vital signs according to the progressing of the case. But some people will use like temperature probe, defibrillator, that's usually around. If they need more like central lines or central venous pressure and capnography, it's always going to be around. What's other requirement? Do you need PPEs? Do you need stethoscopes? Do you need like airway management and like surgical lines? And then it will go to the other aspect of the pages. It's like your patient data and their baseline status. So your examination is going to be there, the age, the medical history, and all of these information has to be here. So you have to think about all of your patients as a real patient, and you write their like records on the script. And also like the physical examination, because like if the resident asks you what's the physical examination and if there is any change, you have to tell them what they're looking for. And then I like this aspect of the script, which is the main goal of all the scenario or the simulation, is basically you have a baseline of how the patient presents, and if they're alert oriented, or if they like or if how sick they are and everything. And then you have the learner actions. So you have to anticipate what the learners are gonna do to the patient. Are they gonna give them IV boluses or gonna give them a medication? And then what's gonna happen after that action that's like the learner took? So I find it interesting that I have to anticipate all of their all of the changes of the vitals. Like if the resident gave an IV accident 500 bolus, does the blood pressure changes from 100 to like from 90 to 100? So all of these things have to be anticipated and thought of during the simulation scenario. And then you have stages of everything that happens. So if the patient doesn't improve, what's the next stage? And if the resident didn't do anything here, then you go to the next stage where the patient like crashes or become more sick and then like they need intubations or something like that. So for me, this is an interesting, and I like the flow of the simulation. The last step of our simulations is the debriefing, which is a very, very, very important point step that you should not miss. And debrief is undertaken to review, to emphasize, and to provide feedback covering the goal and the objectives. And this is a guided period of self-reflection that should take approximately twice as much time as the scenario itself. The debriefing is done. It's just, and most important is thing to think about in the debriefing is it has to be done to neutralize the feeling of stress and high adrenaline rush that the learner were having during the scenario. So you have to make it as a safe environment, neutralize of emotions, not judgmental as well. Ask the learner what they learned, how they felt, and if mistakes were done, you never like pinpoint at a learner that they did something mistake, but just like to cover it in broad in general. And it's a nice space for reflection and to learn all the points that were done in the simulation scenario. So my take-home message from this talk is simulation is a growing field of medical education, and it has an important role in education and teamwork, communication, and procedure skills. And the simulation scenarios themselves are done in several steps. You have to take them all into consideration, and it should be done in a safe, non-judgmental environment. And the debrief is a very, very, very important step in the simulation scenarios. This is my resources, and thank you. Any questions?
Great talk. We don't have a lot of those topics, so original. I like it. Do you think we could actually use those templates when we organize ourselves as residents, the sim?
Of course. I usually send it to the residents who are responsible for the simulation, like the year after me. But anyone who's gonna do simulation for our ground, what's called our simulations or anything, yeah, you can take it.
Yeah, because I think that could be a nice way first for us to actually practice this way of thinking and having more thorough sims for the big sims, not the recess hours, but for the big sims. That could be great.
Sure.
All right, so if there's no other questions.
I have a question.
Oh yeah, go.
Hi, Dana. It's Gemma. Sorry, I don't know if you can see me, but my question is pertaining to the use of technology. So we've been doing sim in the CCFP program like once every week or two, and it's super helpful. And I was just wondering if you've seen any research that looks at like what aspect makes the sim most helpful in terms of does it really matter if you have these high fidelity pieces of equipment, or is it like the tone of voice and the ability of your standardized patient to seem realistic? Is it the change in the vital signs? Like what aspect of the case do you think makes the most learner impact? Because for me, I find that the equipment itself, when we're doing it, it doesn't really matter to me if there's a high fidelity mannequin. We don't ever really place the IV. We don't, unless it's like a dedicated airway sim day or a dedicated procedural sim day. During the cases, which I've found to be super helpful, we don't really do the actual physical things. And this thing that's the most helpful for me, at least, has been just like the pressure, the social pressure, the acuity of the case, and having to like think out loud and communicate. And I find that that's the thing that's really contributed the most to my real life practice. So I was curious if you'd seen any research on that. Sorry, long-winded question.
It's actually, it's actually a great question, because like I wanted to put two studies that was like with very expensive, very new equipment. And the other study was like done as a low fidelity study that was done, but it was only on like either communication or something. It wasn't in the medical field, but they also found that in without this technology, without like the modern technology, you still can find benefits, and it's very helpful, and everyone learned from like the low fidelity as well, but it was a different teaching aspect. So like not a lot of research has been done in all of these points yet, and as I think they need to do more studies in that. But what I've seen is like there is benefits from the low fidelity. Like as long as you do it and you know what's your point, like what's your goals and what's your objectives are and what you want the learners to learn from you, then I think that was the most important part. The equipment and everything will help you like be more stimulated and want to learn more. But I found they have both, but I don't know the comparison because no one compared the two. There was like studies alone, and also the number of participants wasn't that much. So I cannot really conclude a good like statistics about that.
Cool, thanks.
All right, if any other person have questions, I would encourage you to write it in the chat. And we'll go with the next presentation, who is an other FRCP resident. So Fatma is going to do her grand round on in-flight medical emergencies.
Hello, everyone. Good morning. My name is Fatma. I'm one of the R2s. So today I will present about in-flight medical emergencies during commercial travel. So as health concerns and travel restriction are becoming less and less, the travel operations are returning to their usual activities in a slow, steady rate compared to 2019. So in-flight medical emergencies in general, there are events that could be frustrating for some people. It occurs in unusual environment with limited access to care, and we don't know what to expect. And also it requires people or medical volunteers with limited training or experience with those situations. Based on a review of from 2008 to 2010 of 5 United States airlines, showed that the estimated prevalence of in-flight medical emergencies is 1 in 604 flights. And there is another review from individual airlines from 2009 to 2013, estimated that the in-flight medical emergencies were about 24 to 130 event per 1 million passenger. There is a recent systematic review and meta-analysis of 1.5 billion passengers showed that in-flight medical emergencies were rare events, on average of 18 events per million passengers, and the rate death was approximately 0.2 deaths per million passengers. So in-flight medical events it's a term that uses a wide spectrum of illnesses, ranges from minor illnesses, includes mild headache that's commonly managed by the crew members, or it could be serious that might include deaths and prompt for a ground medical advisor or asking for help from onboard medical profession. So there was a review, a systematic review of 14 articles about frequency and relative medical conditions during in-flight medical emergencies, showed that syncopes and near syncope were the most common medical condition reported in in-flight medical emergencies, followed by GI symptoms, nausea and vomiting, rest symptoms, difficulty breathing, and cardiovascular symptoms was chest pain. And there is another a study review. It was a retrospective study of in-flight medical events that involve pediatric population of 77 airlines worldwide, showed that like the study reviewed around 75,000 calls, showed that among those 75,000 calls, around 12,000 calls included pediatric population. The age population was 18 years old, and the youngest pediatric population was 25 days old. Crew members were able to assess in 88% of the cases, and onboard physician where help was required in 8.7 cases. Among those, I would say 12,000 cases, 16% of them required additional care at destination. And there was 11 patients reported with a primary diagnosis of cardiopulmonary arrest. So in-flight death cases in this study was 11. 10 of them were due to cardiac arrest in flight, and one of them with the primary diagnosis of nausea and vomiting. In this study, the common diagnostic categories in pediatric population was nausea and vomiting, fever and chills, acute allergic reaction, abdomen, gastroenteritis, syncope, and seizure. So during a flight, so what happened within the aircraft cabin? So the cruising altitude for an aircraft during the flight is around 30 to 40,000 feet. The passenger cabin is pressurized around 5,000 to 8,000 feet. An average person could ascend to 7,000 feet without any symptoms. However, the change in altitude is more pronounced with patients with cardiopulmonary events. So, and within the aircraft, the atmospheric pressure is around a quarter, and at the sea level is 1 atmospheric pressure. If we apply the Boyle's law in this concept, we will see the gas volume will expand in high altitude due to decrease in pressure. So at a pressure of 800,000 altitude or equivalent, the volume of gas in enclosed space increases by 30%. So in enclosed spaces in the body like sinuses or middle ear, the gas will expand. And if the passenger have a non-physiological gas collection like a pneumothorax, or any gas collection after surgery like an abdo surgery, ocular surgery, or intracranial surgeries, the gas will expand there and the patient might exhibit some symptoms. So in higher altitude, the oxygen partial pressure will be lower. So a healthy person would have some sort of mild hypoxia, and the mean arterial pressure will be from 97 to 93%. So if you decided to use a pulse oximetry in higher altitude, the oxygen saturation will appear to be low. So any patient with cardiopulmonary or pulmonary conditions may exhibit some symptoms due to decrease in oxygen partial pressure in higher altitudes. The cabin air is dehumidified by circulating within engines. So this air might contribute to dehydration and eventually syncope attack or vasovagal in some passengers. And 50% of the cabin air is recirculated, and due to limited enclosed environment of the aircraft, it might raise the concern of disease transmission. However, a pre-existing exposure in the passenger is the most common cause of disease transmission within an aircraft. So onboard medical supplies. ICAO, or International Civil Organization, is a specialized agency of United Nations that that's responsible for setting rules that regulates international flight safety, and they mandate first aid kits, emergency medical kits, and universal precaution kits for international airlines. However, not airlines follow those kind of mandates. Depends on their regular authorities and their regular or own policies. So in first aid kits, it might contain bandages, burn dressing, just in case of burns that could occur in aircraft, and over-the-counter. Some airlines may have over-the-counter medication within the first aid kit, and first aid manual and incident record form. For an emergency kit, it's the important kit. It have a blood pressure kit, stethoscope, airways, different sizes, pediatric, small adults, CPR masks in different sizes, IV set, and NS, medications like epinephrine, and usual just like you should know which concentration this emergency kit have. Not all of them have an anaphylactic doses. Usually they have a cardiac arrest dose. They have antiarrhythmic. Some airlines have anticonvulsant medications, nitroglycerin, aspirin, and also with each medical kit, they have an incident recording form and manual and instruction about how to use the drugs. Whenever an emergency kit is opened, it's usually the ground medical advisor are already made aware regarding the situation in the during the flight. And the universal precaution kit is usually what you found in PPE card, however, does not include N95. So AEDs. ICAO mandated that any flight with more than 30 passengers should have one AED at least, and a flight attendant who knows how to use it. Not all flights have an AED, and European airlines are not mandated to have AEDs. However, it's always a good idea to to know what you have, what kind of medical equipment you have in the flight. So whenever you are responding to the call overhead, medical volunteers or physicians are not alone. Cabin crews have an annual medical training of BLS, and they are competent in using all emergency life-saving equipment carried on the flight. For minor medical events, they usually manage it by their own with first aid kit and over-the-counter medications. And they are only uses the medical emergency kit under supervision of licensed medical volunteer. And they're very, very helpful in situation of medical emergency situation. They facilitate the communication between the pilot and the ground medical advisor and the medical volunteer. So for medical legal, in United States, they have Good Samaritan law that protects the medical volunteer from liability, except in two situations: willful misconduct and gross negligence. If the medical volunteer asked for compensation, this may jeopardize their standing of law immunity. In United States, Canada, England, Singapore, there is no legal duty for an off-duty medical profession to assist during a in-flight medical emergency. However, in Australia and many European countries, they require the physicians to render or to provide help during in-flight medical emergencies as defined by their case law and civil law. So for flight diversion, onboard medical volunteers only recommend flight divergence, but the decision of flight diversion rests on the pilot on command. The flight diversion decision depends on the nearest airport medical facilities or capabilities, time to treatment benefit, weather, aircraft fuel, patient's desire. In the previous study, the systematic review and meta-analysis of approximately 1.5 billion airline passengers showed that the diverger rate was 11.1 per 100,000 flights, and average cost ranging from 15,000 to $900,000 per implanted emergency landing. And this is a retrospective chart review study from 2008 to 2010, showed that for medical events that prompting medical consultation around 16,000, 7% of those around 15,000 medical consultation prompt for a flight diversion, and 93% of those medical events they were able to manage it within the flight. And of those events, the 15,000 events who their post follow-up data were available and had an EMS request and transport, around 50% of those were discharged from emergency department, and 32% of them left against medical advice. 0.6% of those who had an EMS transport died, either within the EMS transport or in the emergency department. In this study, the medical condition that most frequently result in diversion include a cardiac arrest, obstetric emergencies, cardiac symptoms, and stroke symptoms. So how we would approach an in-flight medical emergencies. So first of all, you should ensure that you have a safe environment and you are capable, you are able to assess an in-flight medical emergency. And then you should identify yourself and state your medical qualifications. Then you will go to the patient, you will assess, you will do history and physical. You will ask one of the flight attendants to stay nearby you so that person could facilitate the communication between the pilot and, if needed, the ground medical advisors. You could also ask the cabin crew to let you know about the available medical equipments. And with each medical event and each medical kit, you have the documentation form, always use it. So those are some cards. I found it in one of the studies. I'll recirculate it later on for you to read it because I found it very useful, or you can just capture it now. So I have two cases. If anyone would if you would like to volunteer.
Yeah, I can go for the first.
Okay. So you heard an announcement of, is there a doctor on board? And you responded. You had a 2-year-old toddler who had convulsions for 2 minutes, and the baby have URTI symptoms. What you will do?
So just like with any presentation like this, the convulsions are finished now, I guess?
Yes.
Okay. So I would take some vital signs, and during the moment where we're actually getting the vital signs, I would talk to the mother to know if there's any pertinent past medical history to this baby, and to know if this is the first episode and if he had other convulsions in the last year.
Okay, so they applied the pulse oximetry, the baby's sitting well, and this is the first time the baby have this kind of convulsion.
All right, do we have a temperature?
So it's 38.6.
Okay. Well, and he's not known for any neurological issues?
No.
And the convulsion itself was a classic convulsion. There was nothing atypical to it.
Yeah, it was a generalized convulsion.
All right. Then I would just continue to look at this baby, as this is most likely a febrile seizure, and we'll give them Tylenol just to decrease the fever. And no, I would not recommend flight diversion if he only sees once.
And if you had a recurrent seizure, would you recommend a flight diversion?
Then we're getting into something a bit more worrisome, I guess. I would have to discuss with the flight and maybe a staff on the floor.
Excellent. Okay. So case 2, who would like to take this?
I can go for it.
Okay. So you heard the announcement and you responded, and you have a 47-year-old male who's unresponsive. What you will do?
So essentially, we'll ask for help, go check scene safety, and then if it's unresponsive, so it's like a pre-hospital, you go with your BLS, so you're gonna check for response, you're gonna check for breathing, you're gonna check for a pulse. Does he have any of those?
So he doesn't have a pulse, but you have noticed that he's wearing a necklace that says "Do not resuscitate."
Okay, so if he doesn't have a pulse, and so basically, I'm guessing at this point you have to like respect his wishes. As you said previously, there is like a ground medical advisor. So at this point, basically, you would call him. Personally, if this was a situation, I'd be a bit out of my comfort zone, but I would confirm with it. But if I see the necklace, I wouldn't resuscitate until I confirm to the ground medical advisor.
Okay, perfect. Would you recommend any flight diversion?
So at this case, to be honest, I wouldn't necessarily. I mean, if he's basically he passed away, he passed away. What is the benefits of like landing at this point? I'm not really sure, but personally, I wouldn't at this point.
Excellent. So in case of DNR order, most of the airlines will refuse to recognize this order and may request a medical assistant. If the medical volunteers comes to the situation and decided not to proceed with the resuscitation as Badr did, it depends on the medical volunteer ethical values and legal knowledge of the current situation, which will be limited, as we don't have a previous history. We don't have access to the electronic medical charts. If the first medical volunteer decided against the resuscitation, the cabin crew may ask for another medical profession. Depends on the airline policies. So in each medical or in-flight medical emergency, it always depends on the airline policies. Okay, so where you should resuscitate the patients in case of in-flight medical emergencies, usually in the back of the airplane near the kitchen or bathroom. However, some of airlines like Saudi Arabia Airlines, they have a prayer room, and they can use and during a flight medical emergency, they can use this area for resuscitation. In case of death or death body, some of airlines, they don't have a place to place a dead body. They are the dead body could be lifted in the seat, or it could be strapped into one seat and laid out in a row spare and be covered with a blanket. However, in Singapore Airlines, Airbus A340, they have they have like a special compartment where a dead body or dead passenger could be placed in. So this is a cross-sectional study among Kingdom of Saudi Arabia physicians about the wellness and confidence of physician in response to an in-flight medical emergency, showed that among all specialties, emergency physicians reported the highest wellness and confidence toward in-flight medical emergencies. So take-home points. First of all, whenever you approach an in-flight medical situation, ensure that you are in a safe environment and make sure that you are able to volunteer during an in-flight medical emergencies. Like a medical volunteer should not be under influence of drugs or alcohol or super tired because of long flight. Always be comfortable with the environment and equipment that you have and the airline policies. You can always ask your flight attendants. And they are very helpful in facilitating the communication between the pilot and the ground medical advisor. Do not forget to document whenever you are in a situation of in-flight medical emergency. And medical volunteers only recommend diversion. The decision rests on the pilots. In-flight cardiac arrests are rare, and the rate of death is approximately 0.21 deaths per million passengers. So thank you. Those are my references. If you have any comments or any event that you have been through, just share it with us.
Okay, so no questions, I guess. So this will close today's session. Very good presentation, Fatma. So we'll see you guys, I guess, next week, and the chiefs will be back at that time. So I'll be hosting next year's with Fred. So have a good end of the day, guys. Take care.